I was actually at another institute for treatment of my cancer, non-Hodgkin's lymphoma, and I knew that a realistic part of having chemotherapy is that you could end up in heart failure, and the risk is low, but it can happen and it's very real. While I was at the other institute, I really kept feeling like something was wrong, My heart, was building enormous amounts of fluid. And I was discharged from there, went home, and just one more pillow after another I'm sleeping on. And I finally said, I have to go to the A-team, which I knew was DeBakey, and I needed to be here at this institute to be evaluated to see what there was. And I was in true heart failure with an ejection fraction of 28, 29, somewhere in there. So that's how it really began, and I spent a week with the team, a little over a week with the team, and I'm here now.
I was diagnosed with heart failure April of 2014, and what prompted me to go see the cardiologist was because over a 6-month to 1 year period prior to that, I just started having very gradual symptoms like fatigue. I couldn't exercise quite as long, but they were so gradual, so subtle, that it took me that long just to realize that something was not quite functioning the way it should be. The biggest cue was the fact that I used to go out and run. I used to run a lot. I'd go out 5 or 6 miles, and gradually over time it got down to the point where I was struggling with just 2 miles. And so at the time, I think I was just entered my 40s, so I was thinking the typical, I'm at the middle age stage and maybe I just need to cut down type of thing. So actually I switched my workouts to doing more short, intense workouts, and I was doing really well with that, but it was still just this persistent fatigue. And then also even at rest, I would find that I would feel the heart skipping beats. And then that's when I realized that something wasn't quite right from a heart standpoint. And then there's even a couple times I felt a little dizzy or even a little lightheaded.
So 40th birthday, had a nice relaxing morning in bed, reading a book. Started not feeling well. I was 6 weeks pregnant, and I thought maybe, I'd never been pregnant before, so I thought maybe it was the pregnancy, I just needed to eat. And it just got worse and worse to the point my husband took me to an emergency center, and they said I either had a stroke or complex migraine, which we all assumed it was a complex migraine, young, healthy. So I had to go to the hospital, get an MRI, and they confirmed it was a stroke. Later that evening, they told me it was because I had heart failure. It was hard to put the 2 and 2 together. It was supposed to be a happy time. It took us 5 years to get pregnant. We had only known I was pregnant for 9 days when I had my stroke. We did in vitro. So yeah, it was hard to comprehend everything that was happening. The first night I was diagnosed, a doctor had already told my husband that I would have to terminate the pregnancy. I found that out later. We got a second opinion. We went to Cleveland Clinic, and they put us in touch with Dr. Park, and she and her team were willing to take our case on. So there were, of course, medications that I couldn't take because of the pregnancy, but we found a regimen that worked, and it didn't really get too bad until my 3rd trimester.
It is a tough diagnosis to have, but realize that it's not a time to retreat or a time to feel defeated. It's a time to now stand up and fight for the life that you want to have. It's very easy to succumb to the thoughts of having this severe disease, but at the same point too, every day is a gift, and you want to live the best life you can. In order to do that, it requires now some careful, daily work in order to have that. And that's what I would say to anybody dealing with heart failure, is that having a quality of life that you want to have is definitely attainable. It's
not all doom and gloom, because that's where I was heading when I first. You're angry and you're mad and you're all of these emotions going on at the same time, and I think it's very natural.
You would be amazed at the inner strength that you have, that we all have in us. It's there in all of us.
My name is Cheryl Kraft.
I'm Wayne Brewer.
I'm Kathy Kurtz.
And currently I'm in heart failure.
I do it with heart failure.
And I am living with heart failure.
Perseverance. I just power through. It was definitely harder in the beginning because you're just adjusting to having children. And then there was a lot of fatigue, a lot of, I can't do this, I'm not gonna make it. We live in a 2-story home, so stairs still can be a challenge. I'm not supposed to carry the girls, much less upstairs, but don't tell Dr. Park that I do. But I would do anything for my girls. So I do it with heart failure.
I think the biggest challenge that I have, well, there are a couple of challenges, but I think the biggest one is really getting individuals around me who don't know about my diagnosis to understand what heart failure is. And for them to be able to understand that not all heart disease is necessarily due to lifestyle factors. I think a lot of people assign a certain degree of responsibility to individuals, assuming that they do certain things and you have this certain outcome. And in many cases, that's true. But for me, I didn't have the traditional risk factors like diabetes, high blood pressure, etc., that would have led to that. So basically, it became the story that I had to tell of this disease that just sort of appeared, and being able to get people to understand that the need to still get themselves checked and be able to have important follow-ups at certain points, because it can pretty much happen to anyone. And so I think that was a big challenge. But then also from a more personal standpoint, I think just recognizing the fact that I have to sort of temper some of my goals a little bit from a physical fitness or athletic standpoint to realize that now the training now is more about health and not training to compete anymore?
I don't live to the disease. I really don't. I live to what I want to do. And what my focus is to get me the best that I can do and do the best I can do and have fun while I'm doing it. And that's all I can do. I don't believe in the woe is me and I don't want people feeling sorry for me. In fact, my team doesn't even know I have the level of heart failure that I do. And I keep it that way because people look at you a little like, oh, I feel sorry for you, because it's, overtly, it's not showing. I don't have an oxygen tank with me, and they're not seeing me do things during the middle of the day. So I'm sort of a different patient.
I try to remind myself that enjoy the day, enjoy it. Don't always look at all the negative stuff and get all upset about the little small stuff. Just try to do the best you can to enjoy yourself. And that's really what it boils down to. And I think that's something that really everybody should strive to do. I think we get caught in all the minutia, the negativity and stuff like that. There's a lot of great things happening all around you. You just got to look at it, change your mindset. And that's what it boils down to, just sort of change how I look at things. And don't get me wrong, it's still a struggle in some cases. But when things are not going the way you want to, you have to ask yourself, well, there has to be a reason behind it.
I know intellectually I'm a heart failure person. I know that. But I guess in my childlike mind, maybe, I feel energetic, I want to do things, I've been snorkeling, I travel, I still work full-time, I fly full-time basically. And so for me, and I know everybody is different, for me, I've been able to continue to do the things that I want to do.
They say moms of toddlers are tired, and I'm thinking, you don't know tired until you have heart failure. Right now I'm able to, I feel like for the most part, keep up with them. I worry about when they get older and more active, I won't be able to keep up with them, and that worries me. Just riding our bikes around the neighborhood or going for a hike. I worry that I won't be able to keep up.
I don't really see it as a challenge, except, and I think the team will tell you that when I do have the echo done every 3 months, and I have it, and I always have this trepidation about what those numbers are. But I've come to learn that the numbers aren't the end-all be-all. So if my ejection fraction was, say, 28 or 29 this time, and it jumps up to 40, and then it's back down to 33, personally, I was freaking when that happened, but when Dr. Trachtenberg explained it, it made it all better. So the challenge for me is to remain calm when I get those numbers, because the numbers aren't the end all be all. It's how you feel. It's on your day-to-day basis, what you're doing, and I feel alive. I feel like everybody else without heart failure. I was actually at another institute for treatment of my cancer, non-Hodgkin's lymphoma, and I knew that a realistic part of having chemotherapy is that you could end up in heart failure, and the risk is low, but it can happen and it's very real. While I was at the other institute, I really kept feeling like something was wrong, My heart, was building enormous amounts of fluid, and I was discharged from there, went home, and just one more pillow after another I'm sleeping on. And I finally said, I have to go to the A team, which I knew was DeBakey, and I needed to be here at this institute to be evaluated to see what there was. And I was in true heart failure with an ejection fraction of 28, 29, somewhere in there. So that's how it really began, and I spent a week with the team, a little over a week with the team. And I'm here now.
I was diagnosed with heart failure April of 2014, and what prompted me to go see the cardiologist was because over a 6-month to 1 year period prior to that, I just started having very gradual symptoms like fatigue. I couldn't exercise quite as long, but they were so gradual, so subtle, that it took me that long just to realize that something was not quite functioning the way it should be. The biggest cue was the fact that I used to go out and run. I used to run a lot. I'd go out 5 or 6 miles, and gradually over time it got down to the point where I was struggling with just 2 miles. And so at the time, I think I just entered my 40s, so I was thinking the typical, I'm at the middle age stage and maybe I just need to cut down type of thing. So actually I switched my workouts to doing more short, intense workouts, and I was doing really well with that, but it was still just this persistent fatigue. And then also even at rest, I would find that I would feel the heart skipping beats. And then that's when I realized that something wasn't quite right from a heart standpoint. And then there's even a couple times I felt a little dizzy or even a little lightheaded.
So 40th birthday, had a nice relaxing morning in bed, reading a book. Started not feeling well. I was 6 weeks pregnant, and I thought maybe, I'd never been pregnant before, so I thought maybe it was the pregnancy, I just needed to eat. And it just got worse and worse to the point my husband took me to an emergency center, and they said I either had a stroke or complex migraine, which we all assumed it was a complex migraine, young, healthy. So I had to go to the hospital, get an MRI, and they confirmed it was a stroke. Later that evening, they told me it was because I had heart failure. It was hard to put the 2 and 2 together. It was supposed to be a happy time. It took us 5 years to get pregnant. We had only known I was pregnant for 9 days when I had my stroke. We did in vitro. So yeah, it was hard to comprehend everything that was happening. The first night I was diagnosed, a doctor had already told my husband that I would have to terminate the pregnancy. I found that out later. We got a second opinion. We went to Cleveland Clinic, and they put us in touch with Dr. Park, and she and her team were willing to take our case on. So there were, of course, medications that I couldn't take because of the pregnancy, but we found a regimen that worked, and it didn't really get too bad until my 3rd trimester.
It is a tough diagnosis to have, but realize that it's not a time to retreat or a time to feel defeated. It's a time to now stand up and fight for the life that you want to have. It's very easy to succumb to the thoughts of having this severe disease, but at the same point too, every day is a gift, and you want to live the best life you can. In order to do that, it requires now some careful daily work in order to have that. And that's what I would say to anybody dealing with heart failure, is that having a quality of life that you want to have is definitely attainable.
It's not all doom and gloom, because that's where I was heading when I first. You're angry, and you're mad, and you're all of these emotions going on at the same time, and I think it's very natural. You would be amazed at the inner strength that you have, that we all have in us. It's there in all of us. My name is Cheryl Kraft.
I'm Wayne Brewer.
I'm Kathy Kurtz.
And currently I'm in heart failure.
I do it with heart failure.
And I am living with heart failure.
Perseverance. I just power through. It was definitely harder in the beginning because you're just adjusting to having children. And then there was a lot of fatigue, a lot of, I can't do this, I'm not gonna make it. We live in a 2-story home, so stairs are still can be a challenge. I'm not supposed to carry the girls, much less upstairs, but don't tell Dr. Park that I do. But I mean, I would do anything for my girls. So I do it with heart failure.
I think the biggest challenge that I have, well, there are a couple of challenges, but I think the biggest one is really getting individuals around me who don't know about my diagnosis to understand what heart failure is. And for them to be able to understand that not all heart disease is necessarily due to lifestyle factors. I think a lot of people assign a certain degree of responsibility to individuals, assuming that they do certain things and you have this certain outcome. And in many cases, that's true. But for me, I didn't have the traditional risk factors like diabetes, high blood pressure, etc., that would have led to that. So basically, it became the story that I had to tell of this disease that just sort of appeared, and being able to get people to understand that the need to still get themselves checked and be able to have important follow-ups at certain points, because it can pretty much happen to anyone. And so I think that was a big challenge. But then also from a more personal standpoint, I think just recognizing the fact that I have to sort of temper some of my goals a little bit from a physical fitness or athletic standpoint, to realize that now the training now is more about health and not training to compete anymore.
I don't live to the disease. I really don't. I live to what I want to do. And what my focus is to get me the best that I can do and do the best I can do and have fun while I'm doing it. And that's all I can do. I don't believe in the woe is me, and I don't want people feeling sorry for me. In fact, my team doesn't even know I have the level of heart failure that I do. And I keep it that way because people look at you a little like, oh, I feel sorry for you, because it's, overtly, it's not showing. I don't have an oxygen tank with me, and they're not seeing me do things during the middle of the day. So I'm sort of a different patient.
I try to remind myself that enjoy the day, enjoy it. Don't always look at all the negative stuff and get all upset about the little small stuff. Just try to do the best you can to enjoy yourself, and that's really what it boils down to. And I think that's something that really everybody should strive to do. I think we get caught in all the minutia, the negativity and stuff like that. There's a lot of great things happening all around you. You just got to look at it, change your mindset. And that's what it boils down to, just sort of change how I look at things. And don't get me wrong, it's still a struggle in some cases. But when things are not going the way you want to, you have to ask yourself, well, there has to be a reason behind it.
I know intellectually I'm a heart failure person. I know that, but I guess in my childlike mind, maybe, I feel energetic, I want to do things, I've been snorkeling, I travel, I still work full-time, I fly full-time basically. And so for me, and I know everybody is different, for me, I've been able to continue to do the things that I want to do.
You know, they say moms of toddlers are tired, and I'm thinking, you don't know tired until you have heart failure. Right now, I'm able to, I feel like for the most part, keep up with them. I worry about when they get older and more active, I won't be able to keep up with them, and that worries me. You know, just riding our bikes around the neighborhood or going for a hike. I worry that I won't be able to keep up.
I don't really see it as a challenge, except, and I think the team will tell you that when I do have the echo done every 3 months, and I have it, and I always have this trepidation about what those numbers are. But I've come to learn that the numbers aren't the end-all be-all. So if my ejection fraction was, say, 28 or 29 this time, and it jumps up to 40, and then it's back down to 33, personally, I was freaking when that happened, but when Dr. Trachtenberg explained it, it made it all better. So the challenge for me is to remain calm when I get those numbers, because the numbers aren't the end all be all. It's how you feel. It's on your day-to-day basis, what you're doing, you know. And I feel alive. I feel like everybody else without heart failure.
Hello, I'm William Zogby. I'm the chair of cardiology here at Houston Methodist, and it's a pleasure for me to welcome you today for this special conference, the Houston Management of Heart Failure Conference. This is really a special one because it addresses your needs as patients on how to live with heart failure, but also importantly, how maybe to prevent heart failure. So our organizers, headed by Dr. Bhimaraj, who is the interim chair of the heart failure group, have put together an amazing, actually, panel of speakers this morning to address these specific issues of your medications, diet, how can you cook for heart failure to prevent exacerbations, and also how do we prevent heart failure in the future by taking care of your blood pressure, your diabetes, and taking your medications. So I think these are very important conferences because knowledge is very powerful. The more you know about the disease process of heart dysfunction, the better you can live with it, and actually the better quality of life that you will have. So I want to thank you for joining us. I want to thank Dr. Arvind Bhimaraj and his colleagues for organizing this special conference for you today. And I do hope that you can pick some caveats and some pointers of how to improve your life when dealing with such issues. So have a wonderful day on behalf of all of us.
Good morning to everybody watching this live transmission from the DeBakey studio in Houston. And good morning to those in the United States, and good afternoon and good evening for those of you watching east of the world. I am Arvind Bhimaraj. I'm the interim division chief for the Division of Heart Failure at the DeBakey Heart Center, and I'm privileged to welcome you to the Houston Heart Failure Management Conference for individuals affected with this diagnosis and for people who care for them, and all those who are interested to learn about this condition. And I'm privileged and really lucky to have Dr. Wayne Brewer, who's currently at home recovering from a knee surgery, but his dedication to our mission essentially proves that he did not want to miss this. So Dr. Wayne Brewer is an associate professor of physical therapy, but more importantly, my partnership with him is because he unfortunately has been inflicted with this diagnosis of congestive heart failure, but has learned to live successfully with it and has partnered with us and our institution in helping this mission to promote what we call as self-care and taking control. So Wayne, thank you very much for being here today, and I'm honored to have you as a co-host of this conference. And as the day goes by, I was telling him earlier, feel free to get up, walk around, because I know you're recovering, and we'll hopefully have a good time through this through the day.
Well, thank you, Dr. Bhimaraj. It's a pleasure to be here.
All right.
Definitely wouldn't miss it.
Thank you. Thanks a lot, Wayne. So we will move forward with the agenda for today, and there's some logistics. I'll walk through the agenda for today's conference, and we'll start with really why we are here today and why we have to have a conference like this. So we'll move on to my first presentation, which I lead. So why we're here today is because the disease that we're talking about, or the medical condition that we're talking about, is a chronic disease which individuals inflicted with have to learn to live with it. It's not like a back pain that goes away. And most of the models of medical care, classical medical care, are historically have not really created a healthcare system which tells people how to live with it. So what we had decided, this was many years ago, with a mission that I recognized that people really need to learn what this disease is, literally like we have medical conferences for physicians and other healthcare professionals to learn about this disease. If you have this diagnosis, the best success is for you to learn about this. And grateful to our institutional mission, and grateful to the partnership of our the DeBakey studio here, and people like Wayne Brewer and other patients of ours, we were able to create this forum so that we can empower you as individuals who are either dealing with this diagnosis or taking care of people with this. So it's essentially taking control of not just your health, but your health care, and making this a team of a partnership between your physician, your healthcare team, and you as an individual. Because the typical many conditions, including sometimes the reality of today's world, doctor-patient relationship is about, I'll follow instructions and then we're delivering care and then just take these pills. But as the disease gets complex, as the condition gets complex and you have to learn to live with it, I think what is important is to create a team and essentially a partnership with not just one or two people, but the whole system that's available to help you live successfully with it. And to be honest, the term heart failure itself needs to change. We as a community realize that, and it, you start off with a negative finding. You're not failing. It's not a failure. So we're trying to find a better term, but it's heart dysfunction is one way of calling it, and that's really what it is. So we're trying to take the failure out of heart failure, and hopefully, living successfully with this. It starts with understanding a little bit of what we mean by the term congestive heart failure. One of the problems historically that we have created in medicine is this condition comes with so many terms. So you will hear people talk about congestive heart failure, cardiomyopathy, CHF, HFpEF, HFrEF, and dilated cardiomyopathy, genetic cardiomyopathy. Unfortunately, we have created this bucket of confusion. There is a purpose for those terms, but when you get these terms inflicted on you as an individual with this diagnosis, it gets confusing when people use different terms. But the basic concept of a heart dysfunction is laid out in this slide, which the world of cardiology about 10-15 years ago realized that we need to create this paradigm where we can show that a heart can be at risk of getting impacted, which is a stage A, what we call a stage A heart failure, where people don't have any congestive heart failure or heart dysfunction, whichever way we want to call, but you're at risk for it. And that's a huge implication to remember that hypertension, diabetes, those are very prevalent diagnoses, actually puts you at stage A congestive heart failure, not to make you afraid of the future, but to really take control and say, I got to control my high blood pressure, I got to control my diabetes, so that in the future I'm not going to get the congestive heart failure. So that's the relevance of this early recognition of people who are at risk. Stage B is when you don't have any symptoms, so you're walking around feeling okay, but then the heart dysfunction, there's a structural changes in the heart, as simple as when you look at the ultrasound of the heart muscle looks thicker. When you look at the EKG, you can have some abnormality. So those individuals we call as stage B, where you don't have any complaints yet. And then stage C is the bulk of individuals who get diagnosed because they reach out to the healthcare system saying, I'm not feeling well. So those are symptomatic individuals, and that's the bulk of patients that we care for in the hospital or in the clinic. And of course, there's a long journey once you get diagnosed with congestive heart failure. If things that we do, there's a lot of tools that we have available, medicines, devices, and if all those fail, unfortunately, there's a cohort of individuals who become stage D, where we call as advanced heart failure, in whom we have to explore replacing the heart, which is heart transplant, mechanical heart pumps called as LVADs, and they've also become quite a viable option. So I say the worst case scenario, we should avoid getting to stage D, but even if you end up in stage D, the good part about today's world is we have some options that everybody should be aware of. But the crux of these efforts that we're making is, one, to avoid getting heart failure, and two, even if you get the diagnosis, by appropriate care, you should not progress through this to stage D. But there's a lot of investment that needs to happen in that stage C when people get the diagnosis. So let's spend a few minutes understanding what congestive heart failure means. And this comes from, we have to understand what a normal heart looks like. So in the normal heart, you have a cartoon here playing, showing a left side and a right side, and blood comes into the right side through the body, which is unoxygenated blood, and then it goes into the lungs, and the lungs is where you breathe in oxygen, and that oxygenated good blood goes back into the left side of the heart, and then the left side of the heart is what pumps blood out into the rest of the body, hence getting the oxygenation and nutrition to the rest of the body. So that's why the left ventricle, or that chamber that was pointed out earlier, is the main pumping chamber of the heart. A lot of discussion and a lot of relevance when we say heart failure is really a focus on that left ventricle that I just showed, even though there are conditions like pulmonary hypertension and lung conditions that can affect the right ventricle, and there's a whole area where we talk about heart failure because of the right ventricle. But the most relevant discussions across the world, most prevalent, is about the left ventricle. So, and it's really important to distinguish what kind of heart failure does an individual have. The reason being, if you have something called as systolic heart failure, which is currently called as heart failure with a reduced ejection fraction. An ejection fraction essentially is the amount of blood that your heart's able to squeeze out. And 50% is considered as normal. As much as it is an important number to distinguish between these two entities, sometimes individuals get too focused on the ejection fraction. It's not an end-all and be-all, but the reason why ejection fraction gets a lot of importance is you want to know whether you have heart failure with reduced ejection fraction, HFrEF, or heart failure with preserved ejection fraction. The reason being, most of the medicines that we talk about, which is a laundry list of meds, have been shown to be beneficial in systolic heart failure. The other kind is still getting more and more discoveries, and recently one of the medicines actually was approved for the heart failure with preserved ejection fraction. And the reason why somebody has congestive heart failure is another focus where you and your healthcare team should try your best to identify the reason, and not going too much into the details, but there's a significant amount of workup that needs to be done. So in heart failure or dysfunction, what happens is, say for example, somebody gets a heart attack, the left side of the heart does not contract well. And in this cartoon, you'll notice that because the heart muscle gets damaged, or it could be other reasons where that we call as cardiomyopathy, where the heart muscle doesn't beat well, your ability to exercise comes down, and then the blood backs up into the lungs, causing what we call as congestion, and hence you have shortness of breath, fluid retention. And the concept of fluid retention essentially means that your blood's not flowing that well. In this cartoon, you'll see that the blood backs up and slows down, and all that water comes out of the blood vessels, and hence you have these symptoms of what we call as congestion, and hence the term congestive heart failure. So the formula for success that we are encouraging and promoting is understand what your diagnosis is, identify your needs, and then explore options. So today we'll spend some time focusing on the agenda. Today we'll focus on how do I understand what are the resources we have, how do we identify the needs, do these apply to me, and then are these relevant for me? I think these are areas that we'll focus through the day in today's conference, and hopefully all of you will gain out of this. Another important area, as I said, we have partnership. When you're, as an individual, you're partnering with the healthcare team, you need people to help you navigate this journey, and caregivers, family members, friends, they are extremely important to acknowledge that as you are dealing with the burden of the diagnosis and disease, the individuals who are helping you also go through the burden of this state. So for us to also make sure that you're getting relevant support, we have started a support group. As I mentioned, Dr. Wayne Brewer has been instrumental in this, and if you're interested in participating, it's all through Zoom right now. Reach out to him, and this is his information up on the screen. So we'll focus today on taking control of your heart, your health, and also your care. So the first section of today's agenda, we will, after wrapping up with my presentation, we'll talk about some aspects of how do medicines and symptoms help for heart failure, and we'll talk about COVID-19, which has been a major impact on everybody in the world. But when you have congestive heart failure, what is relevant, and then we'll talk about some of the technologies that we can use to manage heart failure, and we'll have some discussion based on those topics. And the second session will focus on things relevant to individuals who are affected with this diagnosis. So we're grateful and happy to have few of our patients and their caregivers dedicate their time today so they can participate and keep these discussions relevant. And finally, the session 3, we will wrap up with aspects that are typically not covered in your visits with your doctors on how to cook, how to eat healthy, and then what are the physical activities that you can do with this diagnosis. We're lucky and grateful to Chef Peter Cox, who has helped us along with our dietitian Angela, and you will see that in the cooking demonstration. He will show things relevant to how you can cook as a individual or a caregiver to keep things healthy, more so with low sodium cooking is relevant to congestion. I also want to point out that this conference, when it was in person, all those videos are actually recorded and available on our DeBakey CV education website. So there's much more information you can get, more than what you will get today in these pre-recorded conferences. So please feel free to go watch them at your leisure and at your convenience. I want to acknowledge the following two companies, Abbott Laboratories and Boston Scientific, for providing an educational grant to support this activity. I also want to thank the Friendly Faces Senior Care to support today's activity. And then we have an exhibit hall which you can use this QR code to scan to essentially go to these exhibit halls. And some of them are informational, where we have the DCM Foundation, the Heart Failure Society of America, our cardiac rehab program, and the Texas chapter of American College of Cardiology, where you can visit their websites for the information and resources for this condition. Absolutely, if you're on social media, these are all the media that you can use. If you have any questions through the web or text, go to pollev.com, and as these topics are being discussed, please submit questions so we can discuss these things. With that, I will end my presentation, and we will move on to our next speaker, and hopefully Dr. Kim is on the call, on the Zoom call. We will we'll have Dr. Kim talk about medicines and symptoms, what to look for and how to manage. Dr. Ju Kim is an advanced heart failure cardiologist. He's my partner. He's a director for the critical care unit, cardiac critical care unit co-director, and has done a phenomenal job in helping us manage our sickest of the sickest patients. But he's also very passionate about patient empowerment. And thank you, Ju, for being here on a Saturday. And I will hand over the podium to you.
Bhimaraj, thank you for the invitation, and thank you to the audience for joining. And I have shared my slides. Hopefully you can see those. So my charge is to talk to you about navigating heart failure symptoms, as well as the medications that we use to control those symptoms. And as Dr. Bhimaraj started my morning off, I think it's important to know what it is that we're trying to manage and with what. So here are the take-home points that I want you to know just right off the bat. with regard to symptoms, get to know your symptoms. I'm going to go through the laundry list of potential ways that heart failure can manifest, but get to know your symptoms so that we can track those and manage those. Do not ignore them. And please, communication is going to be very key between you and your caregivers, as well as your physicians and medical team. The symptoms can be managed. So please do not ignore them and please track them. With regard to medications, learn your medication regimen. Keep a list updated and know that we can also manage any type of side effects. So let's get started. Heart failure, the common symptom or the cardinal symptom of heart failure is breathlessness or shortness of breath. And these common symptoms are due to extra fluid or congestion, as Dr. Bhimaraj explained, in terms of how this fluid builds up. But congestion can not only involve the lungs to make you short of breath, but it also can affect different parts of the body, including the abdomen and legs. And when the heart also gets weak, as we discussed in the first presentation, the ejection fraction may fall, but also the cardiac output, which is the number of liters per minute that the heart circulates blood around the body. If that number falls, then that also compounds the symptoms that you may feel in terms of breathlessness, whether it's shortness of breath with ordinary activity or shortness of breath mostly at night when you're trying to sleep. And when you have congestion, as I said, congestion can manifest in many different ways, and not everybody will have the same symptoms. You may be someone who gets more swelling in the legs, and you may be someone that doesn't get any swelling in the legs. You may be someone that accumulates fluid mostly in the abdomen, and you may get fluid built up there. That will lead to things like weight gain. Or I also included weight loss there because heart failure, especially when it's chronic over long term, actually becomes a catabolic process where the body starts using things like your muscles for energy. And so even though you may be accumulating fluid and gaining weight, you can also lose weight and your nutritional status can also suffer. Now, when you have all this congestion, again, it may be that you feel more tired easily. You're not able to do the ordinary activities that you're used to do, whether it's making a loop around the grocery store or getting to the mailbox and back. You may start coughing, and an initial cough may just be a dry cough, but eventually you may also start to notice some phlegm that may be thin, white, or even colored. And with enough congestion, some folks feel so short of breath that they're not able to sleep laying down in bed. And folks will come and say, usually I'm able to sleep with one or two pillows and on a side sleeper or back sleeper. But for the past week or so, I've needed to prop myself up. And now I can't even, I'm sleeping most of the nights in a reclining chair. So these are all congestive type symptoms that you should be monitoring. And again, if that cardiac output falls and the heart's not able to really meet the demands of the rest of your body, we can even get to the point where the brain starts seeing less cardiac output. And not only will you be tired, but you may feel lightheaded. You may have concentration difficulties. Some folks will report symptoms of things like depression. And if the blood pressure drops or if you have abnormal heart rhythms, some folks may even either come close to fainting or faint. And again, when the heart has diseased, with whether it's heart failure or whatever the other conditions that may be contributing to it, you may also feel things like fast heart rate or palpitation, irregular beats. You may feel nauseated. If the gut becomes very swollen, the motility throughout the body will slow down. And so small amounts of food that you eat may make you feel full. And sometimes folks even lose appetite as a result. And that again contributes to potential weight loss. So ultimately, the key is to track these symptoms, get to know what your symptoms are, talk about them with your medical team, and track them. And this is a really nice self-check plan that I found on the American Heart Association website, riseabovehearthf.org. And you can track these symptoms and get to a point where you can understand where some of the warning signs may be, so that you don't ignore them and address them in a timely manner so that you don't get to the point where down in the red, where it's now becoming an emergency that you need to get not only immediate medical attention, but potentially hospitalization for immediate care. Now, moving on to the heart failure therapies, medications really are only a part of your treatment plan for heart failure. And hopefully we'll spend the rest of the conference also addressing various ways that we will manage this chronic disease. But lifestyle changes, cardiac rehab, devices, surgical procedures, these may all play a very important role in the overall ways to manage your chronic heart failure. However, medications are a key part of that plan. And unfortunately, medications that belong to several different classes with different mechanisms of action are known to be best for treating heart failure. To give you an idea, I will share with you the algorithms or the guidelines that your physicians or your medical team is referencing when they're trying to manage your heart failure. And this is a set of guidelines that's been endorsed by multiple professional societies, including the American College of Cardiology, the American Heart Association, and the Heart Failure Society of America. But ultimately, I'm not sharing this for you to memorize this, but to say that there's many different tools and many different ways that we need to take advantage of to treat your heart failure. And when it gets to the building blocks of medications that we use to treat your heart failure, really we start, and diuretics are going to play a big role. And these diuretics are designed to get that congestion off of you, so to maintain the normal fluid balance. But on top of that, really are these four pillars of medications, all of which act in a different mechanism of action. And really the ACE inhibitors, the ARBs, and the sacubitril valsartan, or a medication known as Entresto, these medications, beta blockers, aldosterone antagonists, you may see some names that you recognize if you're a heart failure patient here. These all act to counteract the way that the body responds to heart failure. And that initial response to heart failure that our body has is to try and preserve that cardiac output as best we can. But over time, chronic activation of that response system actually becomes deleterious and can worsen the process. So these classes of medications have been studied and proven to be beneficial in heart failure, not only to keep folks out of the hospital, but to keep you alive. So I think it's really important that you're on the right guideline or evidence-based medications. The newest class of medications that we're using now that you may start to see in your medication list are these SGLT2 inhibitors. And this class of medications was initially designed for diabetes management, but again, with lots of studies have now shown that this class of medications has been wonderfully advantageous for heart failure patients, both again in terms of not only keeping that congestion down, but keeping you out of the hospital and keeping you alive. So in terms of side effects, there can be lots, but I put this on there, whether it's an allergic reaction that would be very severe and needs immediate attention, but it can also be a cough, lightheadedness, fatigue. Notice those are the same symptoms I shared with you in the beginning of the presentation that are common with heart failure. So there may be times where you start taking a medication and say, I'm not feeling any better. My cough, I didn't have a cough, but now I have a cough. And so some folks may be tempted to say, this isn't working. I don't want to take this anymore because the side effects are too much. I would encourage there be a good dialogue between you and your medical team so that you know which of the side effects or the symptoms that you're feeling are due to the medication versus heart failure. And lots of the medications that we use to treat heart failure also need to be monitored for things like toxicity, whether it's electrolyte imbalances or worsening kidney function. So please be mindful of the side effects, but also the key message I think would be to maintain the line of communication with your medical team so that you can manage these. Now, The trouble with heart failure medications is that in the very simple slide that I showed just a minute ago, there's already 5 different classes of medications. And most patients with heart failure don't just have heart failure alone, but may have had some comorbidities that led to it, or have other chronic medical conditions. And a study back, I think, in 2017 showed that patients with heart failure see an average of 8 different providers that prescribe medications. And that can lead to potentially receiving conflicting advice and would lead to medication management issues. And you may have problems with multiple medications if you take medicines for multiple health problems. You take more than 5 pills, and I've just outlined 5 medications just for heart failure. You receive prescriptions for more than one physician, or you were recently hospitalized and they took your medication regimen that your physician had, but went into the hospital and you came out with an entirely new list. And these are common things, but again, speaks to the importance of good communication between you, your caregivers, as well as your medical team to avoid or minimize the risk of these kind of complications. And so one of the things that I insist for our patients is that you maintain a medication list, create one. And these are some suggestions that I made up, but also are available in pre-printed lists, available even on the internet. Know the name of the medication. What is the dose? How often are you taking it? When are you taking it? What's it for? Who is responsible? Who's prescribing this medication? What are the things that I need to be watching for with that particular medicine? So I think ultimately, these are really the salient points for medication management, and which is to know the name and the purpose of each medication that's prescribed for you. If you don't understand why you're taking something, ask the person that's prescribing it. Take the medicines exactly as prescribed. Otherwise, it may not work as intended, or it may lead to undesired effects. Maintain that list and bring that list or the pills, even the original pill bottles, to your physician appointments, or certainly if you end up in the hospital, please have a medication list available so that we can avoid any unnecessary errors. And set strategies up for management, whether it's to organize a pill box or set alarms on your phones, or using some of the smart technology that we will address even later in the conference. Make plans for travel if you have to be away for the weekend. Make sure you have a mechanism where you can keep the medications arranged. And again, the last point I think is key. Please maintain a good open line of communication between you, your caregiver, and your medical team so that we can manage these complex list of medications. So in summary, the take-home points are, again, to get to know your symptoms. The symptoms can be different for each person. Get to know your symptoms. Do not ignore them, and maintain a line of communication so that we can manage them. Learn your medication, keep a list, and know that we can manage even side effects as long as there's a good discussion about which are side effects or which are symptoms of heart failure. I've included this 2 links here at the bottom, are resources which I think are very helpful. First is from the Heart Failure Society of America. There's lots of educational modules on there that will sort of reiterate and even expand upon some of the points that we'll discuss today. The second link is from the American Heart Association, which again has lots of modules that I think are very helpful for patients, caregivers, and anyone interested with heart failure. So with that, I will end. Please share all questions in the chat box so that we can address them throughout the conference and again during the Q&A session. Thank you very much.
Thank you, Dr. Kim. And as he mentioned, I want to remind the participants on Zoom can type their questions into the chat box. People who are watching this on other platforms with live streaming, as mentioned before, you can send in your questions through text. If you text DeBakey to 37607, or you can go to pollev.com and type in DeBakey. So feel free to type in all your questions, and we will have a panel discussion at the end of these 3 talks. So we'll move on to the next presentation, which is a recorded presentation by my partner, Dr. Barry Trachtenberg. And Dr. Trachtenberg is the medical director for the cardio-oncology program and cardiac amyloidosis program. And in the same essence, as I was mentioning earlier, that the cardio-oncology program that we have is related to the fact that people who have cancer or getting cancer therapies are at risk of congestive heart failure. So that is a subfield that he leads and essentially tells you the breadth of congestive heart failure that can impact individuals. So he's going to talk to us about COVID and what an individual with congestive heart failure has to know about. So we'll play his presentation. Unfortunately, he could not join us live today, and hopefully we can field if there are any specific questions during the panel discussion.
Hi, my name is Barry Trachtenberg, and I'm very pleased to be here with you this morning to talk about COVID-19 and heart failure and what patients need to know about it. So first of all, I think just to get a sense of the overwhelming burden of disease of COVID-19, there's been over 140 million cases around the globe as of April 19th. The US has seen over 31 million cases of COVID so far and have had 567,649 deaths as of April 19th. And there have been over 3 million deaths across the world. To put it in perspective, if you look at the leading cause of death in the United States in the year 2020, heart disease and cancer remain number 1 and 2, but number 3, very close behind, was COVID-19. Of course, some cases of heart disease may have been mixed in with COVID-19 and really could also, this could be underestimating the degree of death due to COVID-19. But COVID-19 was a more common cause of death than injury, stroke, COPD, Alzheimer's, diabetes, etc. There are certain groups that are at higher risk of having severe cases of COVID and of dying from COVID. So patients with heart failure in particular are at increased risk of having severe cases of COVID, including the higher risk of dying. From a global registry that was released earlier in 2020, shows that hospitalized patients overall had a 5% risk of death if they did not have heart failure. But if they had a history of heart failure, that risk increased threefold to approximately 15%. In general, why this happens, we know that heart failure patients are more frail. They have impaired immune responses. And of course, they have less cardiac reserve to handle the hemodynamic consequences of having severe infections. In addition to exacerbating known heart failure, we also know that COVID-19 can cause new onset heart failure by a variety of different mechanisms. This can be due to inflammation and myocarditis. This can be due to sepsis and the effect of just an overwhelming infection. This can be failure of the right side of the heart due to the severity of the lung disease. This can be what we call a stress cardiomyopathy, and just the heart failure due to a significant event in someone's life. And there's other mechanisms as well, including blood clots. So in addition to heart failure, we know that patients, as we increase age, are at a higher risk of dying from COVID. In addition, patients that are obese, minority patients who are more likely to have high blood pressure, diabetes, and other heart disease, cancer patients, patients with pre-existing lung disease and other types of heart disease, diabetes, and patients on immunosuppressive medications are more likely to be at high risk. But I think it's important to stress there are cases of death and severe cases of COVID, even in healthy young people. So there are some limits to the ways we can predict who's going to have a bad response and who's not. There's been so much information and so much misinformation about effective treatments for COVID-19. And this is evolving as the science comes out, and we're learning more and more with new studies There have been thousands and thousands of studies that have come out just in 1 year with this new disease, and we're still learning more. So I say this with a ton of humility, but there are few proven treatments for COVID-19, and none of them are curative. So things that are effective, so dexamethasone, which is a steroid, this is only effective in patients that are needing oxygen. And this is the only one of these that's really shown any modest survival benefit. Remdesivir has been shown to have a benefit in hospitalized patients in terms of decreasing the severity of disease. We have monoclonal antibodies that are available in outpatients, and they've been able to decrease the rate of hospitalizations in patients. We've had a whole bunch of therapies that have been touted and tested and failed, yet still used by a lot of people despite that. These include ivermectin, vitamin C, of course, hydroxychloroquine, which variety of studies have debunked the myth that was a beneficial therapy for COVID-19. And hopefully in a few months, we'll have more knowledge on some of these medications and maybe even additional medications that will be helpful. I think it goes without saying that prevention is the best cure. So vaccines are our most effective treatment to prevent COVID-19. As of today, the day of this recording, there are 3 FDA-approved vaccines, with the caveat that the Johnson & Johnson one is on pause as the FDA is investigating cases of blood clots in 6 patients out of 6 million. These were blood clots in the veins that are in the veins in the head, and 6 patients had blood clots that were fatal out of 6 million patients in that received the vaccine. So approximately 1 in a million patients. I suspect, but at the time of this recording, we don't know, that the Johnson & Johnson vaccine will be reinitiated. It was just reinitiated in Europe with a warning about the potential blood clot issue. So we have 3 vaccines in the United States, and we're expecting that we might have more in the future, especially with some others on the horizon. But Moderna and Pfizer, they're both mRNA vaccines, and we'll talk a little bit about that. They're both very effective, so 94 and 95% effective respectively at preventing COVID. So there's still a 5% chance to 6% chance you can get COVID with the vaccine. However, the cases of those patients that still get it are typically very mild. And these are almost 100% effective at preventing severe COVID and preventing death from COVID. Both these vaccines require 2 doses that are 3 or 4 weeks apart, depending on which vaccine you get. And the Johnson & Johnson is a different mechanism. It's a viral vector, more a traditional vaccine that we've used in the past. It has a 72% efficacy, so it's a little bit less effective at preventing mild cases, but it's still almost 100% effective at preventing severe cases. And benefits of the Johnson & Johnson are that it does require only 1 dose and doesn't have as stringent storing requirements. So for the J&J, as I mentioned, there is a safety pause due to the cerebral venous blood clots. And just to put that in perspective, if you have COVID, there's a 1 in 5 chance you'll have blood clots, typically different types of blood clots in the veins in the legs or arteries, or the arteries to the lungs. 1 in 3,000 women on oral contraceptives have risk of blood clots. Again, these are usually in the legs or the arteries to the lungs. And if you have COVID, your chance of dying is much greater than the 1 in a million, even for healthy young people that the risk is for the cerebral venous blood clots with the J&J vaccine. So for all those reasons, it is suspected that this will be back on the table as an option, but as of today, we're still waiting for guidance from the FDA. So some myths about the vaccines. One is mRNA vaccines will change my DNA. I think we hear this all the time, and the fact is these vaccines give our bodies instructions how to build antibodies to the virus. They don't enter the nucleus of the cell where the DNA is made, and they do not change your DNA. Another myth is that the vaccines, I hear this all the time from patients, they were developed too quickly to be safe. The fact is, yes, they were developed quickly. The technology for mRNA has been around for over a decade and has been well studied. And the vaccines were studied in tens of thousands of patients of all races. And since they were approved, hundreds of millions of people have received these vaccines with no major safety concerns apart from the Johnson & Johnson boycotts in 6 patients. And then finally, a myth that the vaccine can give you COVID is not true. The vaccine cannot give you COVID. So I think to summarize, all heart failure patients really should receive that vaccination. That's your best weapon against this. Heart failure medications should not be stopped. Initially, there was some concern that ACE inhibitors and angiotensin receptor blockers, which are very important medications for heart failure, that they may interact with the virus and make things worse. But that's been shown with trials that there's no safety concerns to be on these medications. And in fact, that can worsen your heart failure and increase your mortality if you stop taking them. We do know that we're starting to see data showing that patients that have transplants, including our heart transplant patients or in patients in general on immunosuppressive therapy, that their response to the vaccine is not as robust. They're not getting the antibodies. The percentage of patients that respond and get antibodies is not as strong as the general population. So it's important that those patients understand they still need to be careful, practice social distancing, wearing masks until we have more data in this population or reach herd immunity. So I hope that was helpful and look forward to your questions. Thank you.
That was a good overview, and I'm sure as we hopefully are recovering from the pandemic and maybe there is a light at the end of the tunnel that we will move on. I think these are all questions will remain, and learning to kind of deal with all this relevant information, I think, was very important. And I want to thank Dr. Trachtenberg for his time and effort. Want to remind individuals again, feel free to submit the questions, which we will address after the next talk. And our next talk is about how to use technology, smart technology in living successfully with congestive heart failure. And in the world of Zooms and cameras, like we're using this technology, there's iPhones and iWatches and blood pressures, Bluetooth technology, which can be used successfully, sometimes gets overwhelming. But my partner, Dr. Ahmed Solomon, he's the associate director of our cardiology clinic, but has also been very instrumental in adapting technological innovations to our practice. And we have him today talking about how we can use some of this smart technology for individuals specific to congestive heart failure. And it's a recorded video, but he will be live with us to answer questions when we come to the question and answer.
Good morning. My name is Ahmed Solomon. I'm a cardiologist here at Houston Methodist, and I have the privilege to discuss with you some aspects of using digital technology in your heart failure management. We will try to provide some answers to some basic questions about using digital health. Why would you need digital tools? Does this replace direct care with your clinician? What tools can I use, and how can I report this to my clinician? So heart failure is a team approach, right? Many of you know by now there are multiple team members in your heart failure management. But what is or who is the most important member of the team? The most important member of the team is actually you. Your information, your signs, your symptoms, your physiological data, these are extremely important tools that you provide to your clinician to provide you better care. So let's go over a couple of the more important parts of care for heart failure patients as an outpatient. So number one is blood pressure and heart rate. Very simple. But as many of you know, there are certain medications for heart failure patients that are extremely important to improve your functional capacity, to improve your morbidity and mortality. And this information, your blood pressure and your heart rate, is extremely important for your clinicians to find out how can they optimize your medicinal management. Number two is weight. So we use weight as an identifier for early signs of volume overload, as an identifier for early signs of decompensated heart failure. So this information is also extremely important. The third one, which is somewhat underreported, is activity. So activity is an important sign to show if your functional status is declining. And reporting it also, reporting improved activity, is also a good sign in regards to your medical management. So let's go over blood pressure and heart rate. Simple devices are out there, Bluetooth connected, that basically report and connect to your phone, being it Apple or Android, and maintains a blood pressure and heart rate log. Very simple. It gives very nice graphs and gives an idea of where you were and where you are in regards to your blood pressure management. This is a very important information for your clinician to continue your care. The second part we talked about was weight. Very similar to blood pressure. There are applications and there are devices. So very simple applications on your phone that basically you type in your daily weight or your daily blood pressure and heart rate. And there are devices, scales, that connect via Bluetooth to your device, your phone. And again, very simple, where basically all you have to do is either put your arm in the cuff to check your blood pressure or stand on the scale for it to record it, and that is all you need to do. Now we go back to the activity part again. Again, as I was saying earlier, very underreported. And there are, again, multiple apps out there that either through your smartwatch or a simple application on the phone that you can use to record your activity. Again, why is this important? Your activity levels are an indicator. If you are able to increase your activity from half a mile last month to 1 mile this month, that is a good sign that your functional status is improving. That's a good sign to your clinician that your management is working. But if you were walking 1 mile last month and this month you're barely able to walk 200 feet, that is also an indicator to your clinician that something is going on. Now, the fourth thing that I did not mention initially, and it is used sometimes, and it's according to your situation, is monitoring of abnormal heart rhythms. So this is not necessarily indicated for all heart failure patients, but this is indicated in some situations. So if you are having a lot of palpitations, or your clinician is concerned about something called atrial fibrillation, or premature beats coming from the lower chamber of your heart, these can be useful to identify. And again, not necessarily all heart failure patients, but this is driven by certain situations in some of our heart failure patient population. So now you've got some digital information. They're all on your phone, on an app. What do you do with it? You communicate. Our system here at Houston Methodist, we use MyChart or Epic, and the vast majority, if basically not all, frankly, of these applications or devices can provide a simple PDF file as a report, weekly, bi-weekly, monthly, whichever way that you communicate with your clinician, and you can provide that to them on MyChart. It becomes, it's very simple, as if you're attaching a PDF file to an email. And you send that to your clinician according to what you both agree upon, every couple of weeks or every month or so forth. But this is the simple process of trying to use simple digital tools to identify and provide information to your clinician about your physiological information, being it your blood pressure, your heart rate, your weight, and your activity levels, to your clinician so that they can provide you the best care possible for your heart failure. Thank you very much for the opportunity.
All right, thank you for our speakers in the first session, and I think we have a few minutes to have some discussions and field some questions. I want to remind individuals again, if you're watching this on YouTube, you can type in your questions through pollev.com or go to text DeBakey to 37607. If you're watching this on Zoom, you can just type in your questions into the chat or the Q&A. So I want to open up and have see what the panelists have in mind about some of the questions that are coming in. One of the questions was about how to handle the side effects of these medications, especially when you're having so many pills to take. And maybe this is very timely to start with Dr. Brewer. You've lived this. Sometimes I tell my patients, we're happy when a new medicine comes as a treatment option for heart failure because we see the benefit. But then I also have to say, you are taking another medication, adding on to what you're taking. So Wayne, what are your thoughts, and how did you deal with some of these when you get side effects when we're giving you a bunch of prescriptions for medications?
Yes, yeah, thanks for the question. Yeah, I think the key thing for me is really partnering with my physician. So in this case, you, Dr. Bhimaraj, to really outline what the expectations are, because I think it's difficult when you take these medications and you don't know what the expectations are. Then all of a sudden you start feeling lightheaded or dizzy. But I think if you understand what the expectations are, and then also, be able to work with your physician to see, well, maybe we can kind of drop some of the intensity of the medications down, the dosage down, and then gradually move them upwards towards the levels that they need to be, so that way you become more tolerant. What I found over the years is that what was intolerant for me in the very beginning is now very much tolerant for me now. It just takes time for me to adjust for the medications, and everybody's different. So I think definitely having an open dialogue with your physician, and then also recognizing that a lot of these side effects, you may not necessarily have them for a long, long time. It just may be time for you to adjust.
Well, thank you, Wayne. I think those are really meaningful suggestions. Setting the expectations. Sometimes when you have to probe and ask your healthcare team on what should I expect and what do I do if I get these side effects to deal with. And then one comment I want to make in what Dr. Solomon had suggested, the role for blood pressure monitoring and how to keep a log. I think one of the important aspects to remember is the medications that you take for heart failure can drop your blood pressure, but the goal of these medications is beyond blood pressure. It's to help your heart, and the reason to keep a tab of these recordings is so that you can balance out how to increase the dosage of medications and not cause a problem. At the same time, you don't want the blood pressure to be too high. Dr. Solomon, what the syncing of these machines and the electronic medical record, sometimes we're still using a paper log in some individuals, and if people are seeing physicians who don't have the same EMR, what is your suggestion in being able to use their smart technology and take it to the physician's office so that they can look at the information?
Definitely, that's something that we see on a regular basis. I always get sometimes logs written down on a piece of paper or a notebook with a lot of signs and so forth around it. I think at the end of the day, it is the patient. If the patient can have that record on their phone through one of the apps that I've listed, or one of the devices that I've listed, if they already have a blood pressure device, as long as they have it themselves, they can offer it to whichever physician they would like. So if they're seeing their kidney doctor, for example, and the kidney doctor is asking about their blood pressure, they have it on their phone with them during their visit, because just about everybody has their phone with them at a time of a visit, and they show it to them. The primary cardiologist that is managing their heart failure, as you were saying earlier regarding adjusting doses for their heart failure medications, that can be sent to, in our case here at Houston Methodist, on my chart as a message. But at the end of the day, the concept would be that whichever device you're using, you have control over your data. So if you're going to see your primary care doctor, your kidney doctor, your cardiologist, you have the data to offer them for your blood pressure, your activity, your weight, and so forth for the last month to what have you.
Thank you. Very useful tips. We have a lot of questions coming in, and probably I'll combine two of them and ask Dr. Kim. The question is, what are the signs of worsening heart failure? And then another question is, can heart failure get better?
It's a great question. So signs of worsening heart failure, really it depends on tracking your symptoms. So if you have been doing otherwise well on, say, a set medication regimen, but all of a sudden, despite you taking that diuretic at a certain dose, at a certain frequency, you start noticing more swelling, or you're starting to feel a little bit more nauseated or full with less amount of food, or some of these symptoms that we've discussed, then those may be signs of worsening heart failure that deserve attention right away. And I think the key message that I think Wayne had is that communication really is vital. You really need to stay in touch, whether it's side effects or worsening symptoms of heart failure, talking with your medical team and saying, hey, this is what I'm feeling, whether it's worsening heart failure symptoms or potential side effects of medications, I think we'll really get to the bottom of what's going on and how do we address those issues. And the question of whether the heart failure can get better, the answer is yes, sometimes. And it really depends on what it is that led to that heart failure to happen in the first place. And so the cause of heart failure is important. So one of the first things that we do when we see initial heart failure patients in the office is ask the question, well, what happened? And I think in the intro video, Wayne also said, hey, I was one of those people that didn't have those traditional risk factors of diabetes and hypertension, but I got heart failure. So I think that's important, to not only assess for risk factors, but ask the question of what caused this in the first place, so that we can try and encourage heart failure as best we can.
Thank you, Dr. Kim. And I think that's an important concept to remember, that when we say you're living with heart failure, I think the success is about feeling as normal as you can, even if the heart function is slightly weak, is the first success story. Whether the heart failure will improve is related to your symptoms, but in some individuals, the heart function also can improve if you do everything right. And there's still a lot of research that is being done in that area on how can be sure that somebody's heart function can improve. But I think feeling as normal as possible with or without a normal heart function is more important than just having a normal heart function, because in some individuals, even with normal heart function, they feel terrible.
I think that's a good point, Arvind, and I'll ask for Wayne's input into this as well, because, in the intro video, one of the patients, clearly said, you were hanging on by a thread. Is my ejection fraction 27 today? Is it 29 today? Is it 24 today? What is that number? And sometimes that number, although important, it doesn't necessarily translate into how well you're living with disease, how well you're managing this disease, and how well can you, function on a day-to-day basis with this. So, the ejection fraction number is important. Those details are important, but how you define recovery or your success with living with heart failure isn't incumbent on just that one number of an ejection fraction. It really is, what are you able to do? Are you able to live your life? And if you're not, because of symptoms, whether it's related to medications or to heart failure, that is the essence of communication, repeated visits, these monitoring strategies, whether it's smart tools or sometimes implantable devices we'll even talk about, to try and manage these symptoms as best we can, so that regardless of what the ejection fraction number is, you're living well with this disease.
I think to piggyback off of what Dr. Kim said, and also what Dr. Solomon's presentation was all about for me, my ejection fraction hasn't changed a whole lot over the last 6 or 7 years, but in terms of how I'm feeling, in terms of my physical capacity, has certainly improved. And when I think about Dr. Solomon's discussion about tracking, your clinical parameters, so your blood pressure, your weight, your physical activity, and also with regards to your physical activity, how are you feeling after the physical activity? Because, some of you may have watched my video in the past, but at the time when I was first diagnosed with heart failure, I had a high level of physical activity, but then it dropped, but it still dropped to a point where it was still a relatively high amount. So I think to speak to what Dr. Solomon's discussion about tracking your activity is all relative. But then also to think about what Dr. Kim is talking about, I learned to not get so hung up on the ejection fraction, that number, but really focusing on my function and how am I feeling. I think that is a much more important parameter. And then, of course, adding the pieces with the blood pressure, and the pieces with that all provides good information, Dr. Bhimaraj, when I go to see you.
Thank you, Wayne. I think we're a little behind schedule, and to keep us on time, we should probably move on. And as the questions come in, there's one question about plant-based diets. We're going to reserve that for the section where we talk about cooking. So with that, I want to thank the speakers this morning, and please, if you have the time, feel free to hang around. If not, I appreciate you spending time with us on a Saturday. We will take a break at this stage and come back around 10:15-ish. In the meantime, then the second session, we'll have a panel discussion where a few of our patients and their caregivers have volunteered to this morning to be on and help us to answer some of these relevant topics. With that, we'll go on the break. Please visit the virtual exhibit halls of the exhibits that we mentioned earlier for both information and the availability of a lot of these technologies that help patients with heart failure. Thank you all.
I was actually at another institute for treatment of my cancer, non-Hodgkin's lymphoma, and I knew that a realistic part of having chemotherapy is that you could end up in heart failure, and the risk is low, but it can happen and it's very real. While I was at the other institute, I really kept feeling like something was wrong. My heart, was building enormous amounts of fluid, and I was discharged from there, went home, and just one more pillow after another I'm sleeping on. And I finally said, I have to go to the A team, which I knew was DeBakey, and I needed to be here at this institute to be evaluated to see what there was. And I was in true heart failure with an ejection fraction of 28, 29, somewhere in there. So that's how it really began, and I spent a week with the team, a little over a week with the team. And I'm here now.
I was diagnosed with heart failure April of 2014, and what prompted me to go see the cardiologist was because over a 6-month to 1 year period prior to that, I just started having very gradual symptoms like fatigue. I couldn't exercise quite as long, but they were so gradual, so subtle, that it took me that long just to realize that something was not quite functioning the way it should be. The biggest cue was the fact that I used to go out and run. I used to run a lot. I'd go out 5 or 6 miles, and gradually over time it got down to the point where I was struggling with just 2 miles. And so at the time, I think I was just entered in my 40s, so I was thinking the typical, I'm at the middle-age stage and maybe I just need to cut down type of thing. So actually I switched my workouts to doing more short, intense workouts, and I was doing really well with that, but it was still just this persistent fatigue. And then also, even at rest, I would find that I would feel the heart skipping beats. And then that's when I realized that something wasn't quite right from a heart standpoint. And then there's even a couple times I felt a little dizzy or even a little lightheaded.
So 40th birthday, had a nice relaxing morning in bed, reading a book. Started not feeling well. I was 6 weeks pregnant, and I thought maybe, I'd never been pregnant before, so I thought maybe it was the pregnancy, I just needed to eat. And it just got worse and worse to the point my husband took me to an emergency center, and they said I either had a stroke or complex migraine, which we all assumed it was a complex migraine, young, healthy. So I had to go to the hospital, get an MRI, and they confirmed it was a stroke. Later that evening, they told me it was because I had heart failure. It was hard to put the two and two together. It was supposed to be a happy time. It took us 5 years to get pregnant. We had only known I was pregnant for 9 days when I had my stroke. We did in vitro. So, yeah, it was hard to comprehend everything that was happening. The first night I was diagnosed, a doctor had already told my husband that I would have to terminate the pregnancy. I found that out later. We got a second opinion. We went to Cleveland Clinic, and they put us in touch with Dr. Park, and she and her team were willing to take our case on. So there were, of course, medications that I couldn't take because of the pregnancy, but we found a regimen that worked, and it didn't really get too bad until my 3rd trimester.
It is a tough diagnosis to have, but realize that it's not a time to retreat or a time to feel defeated. It's a time to now stand up and fight for the life that you want to have. You know, it's very easy to succumb to the thoughts of having this severe disease, but at the same point too, every day is a gift, and you want to live the best life you can. In order to do that, it requires now some careful daily work in order to have that. And that's what I would say to anybody dealing with heart failure, is that having a quality of life that you want to have is definitely attainable.
It's not all doom and gloom, because that's where I was heading when I first. You're angry, and you're mad, and you're all of these emotions going on at the same time, and I think it's very natural.
You would be amazed at the inner strength that you have, that we all have in us. It's there in all of us.
My name is Cheryl Kraft.
I'm Wayne Brewer.
I'm Kathy Kurtz.
And currently I'm in heart failure.
I do it with heart failure.
And I am living with heart failure.
Welcome back, sorry if you're running a few minutes late, and hopefully all of you were able to check out our virtual exhibits and get the relevant information. Today in the studio for this section, I want to welcome Dr. Heather Chung, who's with me, who's the Associate Chief of Nursing. And beyond that, she's actually been a great supporter of this conference and has extensive experience in really the focus of mental health services and mental health for individuals. And a big part of being inflicted with a diagnosis like this is really how to cope and how to handle it. And to be honest, sometimes the healthcare system by itself has a lot of gaps in acknowledging it and helping individuals and their caregivers to deal with it. I also have Laura Garrick, who's the managing editor of our Methodist DeBakey Cardiovascular journal. She's a science writer and editor, and she is currently in Denver, Colorado, enjoying the mountains. And we're really glad on her abilities to kind of tell us about information and guide us through what information that is really good and bad. If you really go to the website, sometimes you're overwhelmed. I also want to welcome our rest of the individuals on the panel here. We have Taylor Reynolds, who's our nurse in the heart failure clinic, and Taylor did her bachelor's degree at Fitwell State University in North Carolina. She worked at Duke for a few years, and we've been really grateful for her presence in our practice. And as a nurse, she will bring a wealth of knowledge on how our patients and their caregivers can get guidance from them. Thank you, Taylor, for being here. We also have Tracy Iamarino, and Tracy is also one of our nurses. She's been a nurse for about 18 years. Excellent nurses. We are really honored to have our nursing crew who pretty much take the burden of helping most of our patients with congestive heart failure. We also have Diane Rosario, who's another nurse in our practice in the outpatient setting. She will also be on the panel, and Diane also comes with extensive experience as a nurse. And we have Pepper, who's a nurse practitioner who runs our heart failure clinic in the hospital, helping patients transition out of a hospitalization. So these are our healthcare professionals for this section, and we're very grateful for really what I call as the heroes of my world, who are individuals who are dealing with this diagnosis and their caregivers. We have Mr. and Mrs. Trevino on the camera. Thank you, the both of you, for taking time of being here. And then we have Mr. Curry. Also, thank you for being here and taking time. So with no further ado, I'm going to hand over the mic to Laura Garrick to kind of kick off some of the discussions. And the first section of this session will focus on really coping with the diagnosis when you get this diagnosis. And then we'll also talk a little about information that's out there. How do you sift through the information? What are the resources? And the later part of the section, we want to focus on the caregivers who really become the support system for success. With that, Laura, it's all yours.
Hi, well, thank you everyone for joining us for this session on bearing the burden. I'd like to start out by asking the patients that we have here, Ted, and when you first were diagnosed, how did you start to cope emotionally, physically, behaviorally? What were the challenges and some of the solutions you came up with?
Part of my diagnosis revolved around my lifestyle, which needed changing, and there was enormous support from family and friends in helping me make those modifications. I, gave up alcohol after having been a regular drinker for the better part of 3 decades. I've lost close to 50 pounds. I've stopped going to places where the kinds of challenges and temptations that would make those changes difficult, if not impossible. And all the way, I had support from my wife and my parents and my close circle of friends. And frankly, when I had questions, I emailed Nurse Tracy, and she got back to me promptly and told me what to do and what not to do, what to take, what not to take. So it was not without a few turns in the road. I had some negative reactions to the medication initially, and the Methodist folks kind of helped me through that, not without a little bit of pain and discomfort, but I'm pleased at the progress that I've been able to make.
Great. James, did you have anything to add along those lines about how you have coped through your diagnosis and managing it afterward? You're muted. There you go.
Okay, he more or less put everything in perspective. We're fortunate. I want to turn around and thank Methodist, Dr. Cassie, and all the nursing staff for getting me back on track, for giving me another opportunity in life. But everything that has to be done is upon us as individuals to turn around and overcome what we've gone through. So as long as we turn around and take in perspective what we have to do, medication, therapy, and again, some exercise, and everything works out all right into our favor.
Great. So I know Dr. Chung has some slides prepared on the subject of coping. So Dr. Chung, would you like to share those?
Sure, thank you. So just a little background on this. Depression is huge. Anyone, once you're given a diagnosis, the feeling in your emotions is what really takes over. And so you have to recognize that that's a normal state, but how to recognize when you need to work your way through the trajectory of that new news that is now a chronic illness that's going to be with you. Anytime you have to think about your illness can trigger feelings of depression, and just few of the statistics, between 25 to 33% of people with chronic illness experience depression. Women generally have a high risk for depression, and you can see the difference in the stats there. Patients have an increased risk of chronic depression, and when you go to your physician's office, you may see them do what's called a PHQ-9 screening, and that's to help them gauge your level of depression. So once you have those, there are typically 4 buckets that I look at. Your emotions, that feeling of sadness that comes over you, anxiety, you may feel overwhelmed, you may feel some palpitations that go with that, the guilt of, if I had taken better care of myself, would this illness not have been upon me? And sometimes, it's not about what you could have, should have not done. For a lot of folks, it's their genetic predispositions that can then lead to a feeling of anger and mood swings and irritability. So then you go into your thought process, the self-criticism. You can have impaired memory, as you have the worry that can supersede a lot of your thought process. When you think of your physical state, you may recognize that you have chronic fatigue, lack of energy. Sleep disruption is huge and something you need to monitor. We have a society now that we're digitally attached. So how do you even put that away early? Allow yourself time for sleep hygiene. Look at your weight, gain or loss, because sometimes with the depression comes either you stop eating or you overeat. Lack of motivation to do the things that you usually found pleasurable. And then issues, again, substance abuse, and that could include include your use of alcohol, which we've heard here. And then you think of your behavior. In this, you may start finding that you withdraw from your friends and your loved ones, so pay attention to that. And then changing your personal hygiene. Your grooming is important to your emotional well-being. So usually then next comes, I'm not going to read through all of these. You can pick what you can think of tips for coping, but typical easy ones, and we're seeing a lot of science around music therapy. So I would encourage you just to spend time while you're meditating to have music playing in the background. Spirituality is something that research is showing for those who have a strong spiritual faith. You will see yourself navigate your way through some of this. And we know there's a stigma around mental illness and the fact that, oh, now I'm needing to take medication. These are non-pharmacological approaches to help you. If you have a young kid, pet, play with them, enjoy life. The weather right now is nice. Go outside and enjoy yourself. So these are just a list of few of the coping. There's a mammoth other digital approaches. There's Headspace and different ones, but you can always email me, heatherchung@houstonmethodist.org, and I'm happy to connect you with additional resources.
Thanks, Heather. That was great.
Mm-hmm.
Can I just say that probably the creature in my life that has most enjoyed my diagnosis are my Labrador retrievers. We spend a lot more quality time together now that I'm out walking them multiple times a day than we did before the diagnosis came. So from Augie and Davis, thank you for letting me know what was going on and how to get it better and get out there and throw the ball with them and run around the bio with them.
That is exciting.
Yeah.
Exactly.
I like the bubble wrap idea that you have, Heather. All of us probably need stress relief in general. But I think one of the parts that I want to acknowledge and probably hear from Mr. Curry or Mr. Trevino and even Wayne, that to me, my journey in this whole patient conference also has opened up a lot of my perception and understanding, which I'll share an example that when we did the first conference and Wayne was expressing about the emotions he went through, as a doctor-patient relationship, we never talked about it in the office. So one of the challenges is that in the healthcare system, you're coming to me to take care of your heart, and we're not designed sometimes to sit and ask you about how are you able to cope with these. So I feel that's where you have to get cued. You have to have enough support systems to one, acknowledge that we have to figure out some alternative way. So Wayne, I'd like to hear your thoughts on the challenges. Where are you alone? Are you left alone? And is the healthcare system not doing everything that we can? And as much as all of you had to figure it out yourselves. So I'd like to hear your thoughts on what we might need to change.
Well, I think over the last, let's say, 10 years or so, the items that Dr. Chung talked about with regards to screening for depression and giving patients tips for depression, I think across all spectrums, not just cardiac care, but all spectrum. I'm a physical therapist, so we do a lot of that with regards to screening for depression because that influences outcomes. And so I can definitely say that I think the healthcare institution has gotten a lot better with connecting all the dots mentally as well as clinically, and also recognizing that even with mental health, it's not something that's static. It changes. So even with all the things that Dr. Chung talked about with depression, anxiety, it cycles. Sometimes you may have a trigger, something, someone that you may have succumbed to heart failure, or someone may be just recently diagnosed. Then it triggers you off into these sets of emotions that you have to try to center yourself back into. Also, with that, understanding that it is something that's cyclic, and you have to kind of be able to understand and deal with the fact that your emotions will change. I think also enlisting that team. That's one of the things we talked about in the very first patient care conference, that the enormity of this diagnosis and the lifestyle changes that you make, particularly like the ones that Mr. Curry talked about, require a lot of support, a lot of encouragement, because you're embarking on something that's very different, and you got to have those people, whether it's your family, friends, clergy, behind you to support you, and enlisting the medical team. Like, I don't think it's anything wrong with talking to your physician about, hey, I'm not feeling right on the inside mentally. Like, can you give me a referral to a mental health specialist like Dr. Chung or someone on her team to be able to help you cope and manage, so you can do the things you need to, like take your medications, go out for your walks, and employ proper sleep hygiene and so forth.
No, those are Laura. I think I have access to the poll EV here, so I'm getting some questions here. I think I have a question here which says, my stress is with medication management. Do you have suggestions on how to better track or manage my medications? Maybe one of our nurses can try to see how you suggest, and then maybe Mr. Curry's secrets that Tracy shared with how they've succeeded. So maybe we can start with either Tracy or Taylor. How do you manage medicines? What are the tips that you give? And then we'll see if Mr. Trevino or Mr. Curry can talk about how they manage their medicines.
Speaking for what I tell my patients, especially if they're having a lot of hypotension during specific times of the day, I noticed that a lot of patients will just take one big handful of medications. So if they're telling me that that's how they take all the medications, I usually will ask them to try to spread them out over the course of the day, like daily medications they can take in the morning or in the evening. And then if there's 3 times a day, we have to do those. So we try to do in between those dosages. So if they're taking them at 8, 12, and 6, maybe taking something at 10 and 4 to try to help with the different feelings that they're having.
Yeah, in some ways, I learned by, I take furosemide twice a day, and I learned that if you wait too late in the day to take it, you're going to be up all night dealing with it. So I try to do the PM dose of the furosemide as soon as I get home from work. I'm a high school history teacher, so I'm usually home between 4 and 5 o'clock every day, and I take that then. But it was hard experience that taught me that lesson. And again, when I was first diagnosed and suddenly started taking large amounts of medication, one of the, it's simple, but one of those little caddy things has really made it manageable and yeah, exactly, just like that. And I have a morning routine. I wake up at 5 o'clock every morning. I do I go to the bathroom, weigh myself, do my blood pressure, take my morning medication. I set it up every Sunday afternoon. Again, it's just, for me, it's helpful just to have everything the same, makes it more difficult to forget, I guess. And again, if something goes wrong, I just use the little my chart or whatever and email Tracy. And her responses are usually 2 words: yes, no. But that's all I need.
For me, I'm fortunate. I'm blessed. I have my wife to be my caretaker. So she makes sure that I turn around and I take my medication twice a day, in the morning and in the afternoons. In the beginning, when I started on this, I went through some medication that didn't turn around and set too well, and I was fortunate that the doctors that turned around, Dr. Cassie especially, had turned around and made sure to either lower the dosage or increase it gradually, little at a time, to where I'm at right now, that I feel good about what I take. And again, I'm new to this. I never thought I'd turn around and come into this situation my whole life, but I'm blessed and fortunate that I'm here to turn around and see life all over again. I do a lot of exercise. I do a lot of riding now. I used to do marathons way before all this happened. That's what my goals are. I take a little at a time. I don't turn around and try to do too much. And of course, she won't allow me to do too much. But there are a lot of things I still miss doing, but gradually I'll turn around and get back into them. But the medication is very, very important, and know your symptoms, know your limitations, because heaven forbid, man, we always turn around and try to be a little ignorant, thinking that, hey, just a little more, and lo and behold, this is what happens. So just know your limitations, exactly how far you can go and when you should stop.
Can I just piggyback on that and say that first of all, I want to sing Dr. Cassie's praises too. She's also my cardiologist, and she made adjustments to my medication, and I kind of know what all the numbers mean, but I kind of don't. And so my ejection fraction was kind of staying what it was, and then she switched me to Entresto, and I don't know if that's why I got better, but I mean it improved dramatically, and just again to sing their praises, that Entresto is expensive, and they helped me fill out all the paperwork to get it reduced from something like $1,500 every time I refilled it to 10.
There you go.
And again, that's all coming from their office, and that switch. And the last time I measured my ejection fraction, it was between 55 and 59%, which is a significant improvement from what it was when I was first diagnosed in March of 2019. So, and again, I don't know if that's the root cause, but explaining the numbers to me, and then making adjustments moving forward, a willingness to experiment may not be the right word, but to make adjustments and then help me as a patient be able to afford the adjustments was a tremendous benefit, and it helped my spirit ride around. You know, what's that? I'm sorry.
That sure is a lot less pressure to worry about, right?
Oh yeah.
Yeah, and I have to echo the same sentiments for Tracy and Taylor. I mean, certainly, they understand. It's the whole person, right? And then there's cost. The Entresto is very costly. The Farxiga, which is that medicine that's used for diabetics and now has efficacy for people with heart failure. That's
essentially, if you see it advertised on television, it's going to cost you an arm and a leg. And both those drugs advertise on the evening news.
Yeah. They understand that, it's a financial burden. So certainly work with you to get you on programs to help with the co-pays and so forth. And I think that's very important to also talk to your physician about that as well. That this cost.
That's right. Mm-hmm. Well, one thing I can turn around and say, and I speak for more so my wife, the people at Methodist, they sure turn around and help out drastically a lot the medication factor. When you're a little strapped, they'll turn around and come around and help out with some of the doses and all that, with what you call free medication, free samples. So that helps out a lot. So that's one less stress burden that I personally have to go through, financial lens of it, because sometimes insurance doesn't cover everything.
That's so true, and particularly when we're taking so many medications. I mean,
yes,
I'm taking
right.
I think the important theme for the audience to remember from all these stories is that you're not alone in this, and sometimes whoever you're seeing, you need to ask for help and say, look, this is expensive, and we understand that. And Mr. Curry, you pointed out absolutely right. That's the reality of the world. If there are advertisements, they're going to be expensive. So we just have to work through the logistics, but there are always solutions that I think your healthcare team can facilitate with, and I think asking for it is probably very, very relevant. I think to keep the conversation moving, probably this also brings to light, you have advertisements, you have information, you have your healthcare team giving you information. So maybe Laura, you can kind of guide us through what information should you trust, and where do you have to really go, because we can't clone Tracy for everybody or Taylor for everybody.
Hey, you got artificial hearts. Why not?
Yes, I'd love to speak to that topic. So I come at this from two perspectives. I dealt with a chronic illness, will still deal with a chronic illness for 20 years. And so like a lot of people who are watching this, I have spent countless hours Googling symptoms and Googling treatments and wondering, you can go down some rabbit holes and some chat rooms that'll give you some kind of questionable information. It's not always easy to tell what exactly you should trust. And so when I went to grad school for science journalism and then working as the managing editor of a cardiovascular journal, I've learned a lot about the questions to ask yourself and kind of some like green flags and red flags for when you're looking at a website to evaluate its trustworthiness. So I'm going to briefly share some of those right now. Okay, can y'all see my screen?
No. Oh. Yes.
Great. All right, presentation mode isn't working. So there we go. So the biggest question you need to ask yourself off the bat is who's giving you this information. There should be an About Us page that tells you their mission and gives you an idea of why they're telling you what they're telling you. Who runs the site? Are they selling something, or is it a nonprofit that's dedicated to patient information? And take the advice that they give you in that context of what their motivations are. Because, I mean, good or bad, we all have motivations for posting content. You also want to look at who wrote the article. Is it somebody with a PhD, an MD, a nurse? And if not, someone like me who comes from journalism, when I write articles, I better be citing and interviewing some experts that have those qualifications. And most importantly, providing some scientific references. So if you go to a site and you see that they have references to preferably peer-reviewed journal articles, large trials, studies that include more than a handful of people, that's a pretty good sign, because then you can go check those sources for yourself if you want more information. But if you see something where it says just studies say, or research says, and it doesn't tell you where those studies come from or what they are and what the research says exactly, it's kind of a bad sign, because it's really easy to take scientific research out of context. And I don't personally trust anybody who gives me that vague of a reference. Many sites will show you who reviewed the information in peer review. And I try to look for information that's within 2 to 3 years, maybe 5 years at the outside, and that includes their references. So if the article was written yesterday, but everything they're referencing is from 10 years ago, you should probably move on. Science and medicine change constantly as we're learning more information, as you all know. So having something that's very recent is very important. I have created a handout that goes into more detail on all of these things and provides some links to some trusted resources for heart failure management, and that will be emailed to all the attendees and put on the exhibits page. So just some quick hits on the kind of green lights and red lights. I trust the site more if the author is a subject matter expert. They have that PhD or MD after their name, or they interview someone like that. If the About Us section should outline the organization's mission and provide contact information so that you can get a hold of them. It just shows that they're more open. They include peer-reviewed resources for all of their claims. And just one of the easiest ways to kind of start your search is, does the URL, first of all, begin with HTTPS, which means it's a secure site? And does it end with .org, which is usually a nonprofit, .gov, government, or .edu, which is a educational organization? There's nothing wrong with going to a .com website. It's just that .com usually denotes a commercial organization, so they may be selling something, and you just want to make sure that you're checking multiple sources so that you're getting information that isn't biased to try to get you to do something in particular. As far as red flags, the biggest red flag for me, and I see this all the time, is a headline that's supposed to provoke an emotional response. And that goes for pretty much any news, really, but particularly with health stuff. If it makes you angry, if it plays into some deep suspicion you've had, or if it makes you really scared, then it may not be a very straightforwardly written article that's going to give you unbiased information. So just make sure you look at other sources. It doesn't mean don't read it. It just means double check. If you see some odd formatting, if it's, all caps everywhere, they're using a lot of exclamation points, that's pretty much forbidden in professional scientific writing circles. So I just would click away from it. And of course, if something sounds too good to be true or too bad to be true, it probably is. So just double check is always my advice. If anything sounds a little bit off, just see if you can find a source that doesn't cite the exact same sources as the website you're looking at that'll verify that information. Again, if they don't provide peer-reviewed sources, or if their only evidence is an anecdote, it's kind of a red flag. Just because something happened to one or two people doesn't mean it's going to happen to you. Every body is different, and scientific studies that use large randomized controlled studies with a lot of people are the best source for finding out what's going to happen to most patients. If you see manipulator out of context photos, just immediately click away. And if the site is selling something, again, just make sure you double check with other places so that you're not just getting information that's designed to back up whatever they're selling. So that's pretty much it.
And I think along with what Laura just said, which is really important, is that a lot of times those sites will offer things that you can get over the counter. In other words, you don't need a physician prescription, but they certainly can interfere with your medications that you take, if they're herbal supplements or things like that. Talk to your physician. Talk to your physician.
That's an excellent point.
Any change in your nutritional regimen, herbals, because a lot of those things can really have a major interaction with the medication that you take. So certainly even take the article or site and bring it to your physician and have them review it for the efficacy of it.
Yeah, thanks, Wayne. That's a great point. And I'm sure Tracy can say, that happens, and they're happy to help.
Yeah, I think those were really valuable tips, Laura. Thank you for putting that together. To keep us back on track, I think we will continue with the same panel, but kind of try to move on to the next section of focusing on caregivers and the support system, who, as mentioned earlier, have always been very important for the health of the nation, which means the health of individuals who are having health issues, except that we sometimes are not proactive in acknowledging and caring for that. Because when you go to a physician, you are being cared for. I don't think your caregiver is being cared for, but if your caregivers are not able to support, I think the whole formula will fall apart. So again, we have this session, we have not only Mrs. Trevino, but also Diane, who's our nurse, but also was a caregiver with one of her family members who has both sides of the story perspective. I think, Diane, your camera was probably off earlier, but thank you again for your time today. Diane is also one of our nurses in our clinic, just like Taylor and Tracy, who support all of our patients. And I'll hand over the session to Dr. Chung to kind of mediate the discussions on caregivers, stress, and importance of how they need to be taken care of.
Sure. Diane, we'll start with you. If you can share your insight with us on what burden does this play in your own life? Because number one, you're working, and obviously then having to take on the extra burden of being a caregiver. So you want to share some highlights of your story and lessons learned?
Yes. Well, my brother, he was in the military, and he medically discharged. He was he had his diagnosis was congestive heart failure. They found out that he had lupus, and also he was in kidney failure. So he came. They discharged him, and he was to go home to his wife. And his wife told him that, well, I don't know how to take care of you. You need to go to another family member. So he called me, and he came and lived with me. He moved in with me, and one of the things, he had to go on dialysis, and he was in the military when he left, he was very healthy, and he just deteriorated so much mentally and physically. And he fought and struggled to have a normal life again. which changed because his role changed. He no longer was a Navy guy. He was no longer a soldier. He wasn't home with his wife. He had to go to dialysis. He had issues with his blood pressure, and then he has to come live with his sister, his older sister, who's bossing him around. I constantly had to tell him, don't smoke, you can't smoke anymore, you can't drink anymore. So he was going through a lot. And one of the things that I think that really was important for him was that to speak about how he was feeling, how his role changed, how his life changed. And he had a difficult time doing that. He wanted to be a tough guy, soldier, and he had a very difficult time doing that. So through his transition, he was able to get a kidney transplant because his kidney, and the effort was mainly on his kidneys, how much he was going through with his kidneys. And he finally got a kidney, and then he started trying to live his life. He bought a house and everything. He tried to do better, but he always still lived with me. I was his strongest support. And another thing I wanted to talk about is being a caregiver also is all of the diagnoses that he had, just understanding and learning what he went through with all of what he was going through was difficult for him. And we just had to work through it. It was a lot to work through, but we did it.
So when you say a lot, share what that looked like for you. Thanks for sharing his story. What is your story on this journey with him emotionally for yourself?
Well, he was my family member. He was just, I stuck it out with him as much as we could do. I worked with him every step of the way. I went with him to the VA. I tried to understand and learn all that he was going through. I tried to learn all of his diagnosis. It was tough to do.
Thank you so much. That's a wonderful story. So Esther, I'll turn to you if you can share your story on your journey with your husband.
Sure. Well, it's sort of been a challenge for us. This is something that this is something that I wasn't expecting at this time in our lives. We've been married 40 years now. So for me, I'm home, so I get to take care of my husband, make sure he takes his medications and do his meals. We've learned to eat early in the day or later in the day. I make sure he takes his medications in the morning. He'll have something light to eat in the mornings. But it's been something different for us. My husband, he's always been the one he was my rock. He was always the one to worry about me, which now it's reversed. I worry about him as far as his medications and his daily activity at work. I make sure that he sort of limits what he can do. But for the most part, we've managed to live through it, and he's doing a great progress. He's maintaining his weight, and we've been exercising. He's done really well, and I'm here for him, and we've been working together on this journey.
So the key word that you used is the word we, right? So in the we of it, how do you still find time for the I? What do you do for yourself?
Well, what I do for myself is in the mornings, I go for a walk. Every morning, I walk about 8:30 in the morning, and I go to the park, walk for about an hour, come home, and just do what I need to do here at home. And the good thing about this is I'm not working, so I get to dedicate my time to my husband.
And Diane, what do you do for yourself? What's your outlet that you can share with us? You may be on mute.
I like plants. Can you hear?
Yes, we can now.
Okay. I like to plant. I plant tons of plants that have all died recently. But anyway, that's my favorite thing to do, and I like to exercise. But I also wanted to mention that speaking of my brother and all that we went through, and how much he progressed, and how he just started feeling better. He ended up passing away in his sleep. He had 95% stenosis of his artery, and he passed. He finally moved into his house, and he was doing well by himself, and he passed away in his sleep. But he looked peaceful. He was happy. He was happy. He went through a lot. His journey was long, but he did it.
Sorry to hear that, but
I'm sorry to
thanks
hear
for
that.
sharing. Yeah.
Bless your heart for being there for him.
Yeah.
Yeah, I
Major
was there. I was his
victory.
big sister, needling
There
him.
you go. Without you all, where would we be?
Yes, I think the importance of taking care of yourself as a caregiver was well reflected, because sometimes it becomes a conversation where when your loved one is dealing with the stress of a problem, I feel like it's not easy for you to say, I'm sorry, I can't deal with this either. So I think you always should have your own support system if you're not able to talk with your own loved ones. But also important to remember is, we know that based on all these stories and in reality, the success of managing heart failure is not just based on the individual dealing with it, but the caregiver is very important. So maybe sometimes we talk about it proactively, how should the healthcare system or we as doctors involve the caregiver? So Taylor, I don't know if you have any thoughts on how when we're dealing with our patients, when you get a call or when you're talking about medications, how do we involve the caregivers more proactively? Because I'm sure some individuals might want to just do it by themselves, right? And sometimes you have this clash.
So a lot of the times when I discharge patients from their clinic room, I make sure that both them and their caregiver support know exactly the game plan, what's going on, and that both people involved know, when to give me a call. A lot of the issues, especially with COVID, if a patient's admitted to the hospital, I get a lot of calls from the family members with updates, and I reach out to the inpatient staff and do what I can to try and keep the family members okay, because of COVID, they weren't able to visit their family members when they were in the hospital. So just being that kind of support, for the caregiver as well as the patient, and talking them through it, because they're going through their struggles, taking care of the patient as well.
Yeah, I think what you bring up is really important, but also what I suggest to my patients is, make sure you, if you are the caregiver or the loved one and you're not able to go to the appointment, I think in today's world, make sure the individual calls you while the doctor comes into the visit, FaceTime, whichever, so it's almost like you're in there. That way you are incorporated into it. And I sometimes joke around, if for my patients, I'm talking to the individual, but I'm actually looking at the family member in the room, because I know that I'll get more information from the family member. So as a unit, you probably have to actively work towards this. I think we're running out of time, so we'll probably reach the end of this session and wrap up and go on a break so that we can move on with the day. I want to thank all of you. Yes, Esther, you have.
Do you want to just say, give a thank you to Tracy and Taylor? They have always been there for me when I needed something answered on some medication. So I want to make sure that they know how much I appreciate all of their help.
No,
it's my pleasure.
Yeah, thank you.
I echo the
Absolutely.
same sentiments as well.
And I think that's the importance of the healthcare team, where it's not just the physicians that you see, but our 3 nurses here, the medical assistants who support them. I think all together, we're all in this together. So any closing remarks, Heather?
No, this is a wonderful session, and I appreciate the time. And again, please ensure that you pause as the patient and the caregiver to take care of your own mental well-being. Thank you so much. And
I appreciate y'all.
thank you. I appreciate it. Thank you.
Thank you, everybody. We'll be back in a few minutes for the next session with a focus on physical activities and nutrition.
I think there's a resilience, and it was just, it took us this long to get here, and kind of not accepting no as an answer. And so that's where you start doing your research and you find look out for other opinions. That's how we ended up at Cleveland Clinic and then here at Methodist. So just refusing to give up and take it day by day.
My son had open heart surgery. You know, he had a congenital cardiac issue that required him to have open heart surgery 2 Christmases ago. So it put all this in perspective for him. And so knowing that I have heart disease and knowing that he could have succumbed to something very similar, I think puts it in a unique light, because I talked to both him and my daughter about the need for them to get screened properly over time, because it could be more of a genetic issue. But in terms of how they perceive me and perceive, you know, daddy's own mortality, I have yet to have that conversation. I'm almost, in some ways, a bit uncomfortable, you know, having that with them. But on the flip side, I think there is a sense of assurance that I'm doing everything that I possibly can to stay here as long as I can.
I'm in awe over her strength. I truly am. The worst part for me was during the pregnancy, and she's supposed to wear this defibrillator vest. Well, she's pregnant. A pregnant woman needs her rest, and she can't get comfortable wearing it. So at night when she sleeps, she doesn't wear it. So each morning, I would wake up, whether it was to get ready for work or every morning, and I would look over at her and see if she was still alive. You would never know the difference. I mean, it's not like it, you know, I could be sleeping and she could pass in the middle of the night and I wouldn't know. And so every morning, that concern, that not knowing if she was still with me or not, that was the worst part. There were times of, you know, breakdown where you just wanted a normal pregnancy and why me, but you know, it was, as a team, we fought this as a team and we made it through, and we're still fighting as a team, fighting as a family. You know, certainly her attitude and perseverance, faith, absolutely, that was the most important thing. And I was on the sideline cheering her on, doing whatever I could, and just held on to that roller coaster. I find my strength in her strength. You know, again, it's that perseverance of and thinking about others, thinking about her, putting her needs at the forefront, and because I need her around for a while. You know, so we need to make sure she takes care of herself, and that she's okay. You know, we got these 2 girls. They need their mom.
So when I was pregnant, he really had to step up, and he was amazing. Just helping me get dressed or shower. Never complained. Never left my side, and I mean that physically and emotionally, like he was so supportive when I told him that we were going to have these babies. He didn't try to talk me out of it. He jumped on board and took that leap of faith with me, and I'm so grateful for that.
And so I would just, I'd help her when needed, if whatever, and then I would just stay nearby so that if she needed anything else.
Slept every night with me in the hospital except when ICU, he wasn't allowed. And then even in after delivery, he was going to sleep in the waiting room.
During pregnancy, I can't remember how far along she was, but this one night she had just horrible indigestion, just worst I'd ever seen her have it. And so I'm thinking, okay, we need to put her on an incline. She can't sleep. I don't know, it's probably midnight or something. And she can't sleep. The pregnant woman with heart failure needs her sleep. And so I'm thinking, okay, we need to incline the bed. Well, how do you incline a king-size bed at midnight? Then I said, okay, let me figure this out. So I had some plywood and ended up stacking some pillows on the floor, laying the plywood at almost like a bike ramp on that. And then I think we had some other blankets or padding that I put on top of that, and then a sheet. And so it was like this, well, maybe like this, and on the floor. And in the middle of the night, you're just out there, MacGyver this thing together with whatever you have so that, she can try and get some rest.
So I slept on a bike ramp that night. I mean, most people would just throw you another pillow, and this guy built a bike ramp for me to sleep on.
Yeah, in our bedroom, off to the side of the bed.
So that's how dedicated he was to helping me.
Okay, so now we're at the third section of the conference today, and this section is going to entail healthy heart living. And so I have the pleasure to introduce Mr. Alapur Maram. Mr. Alapur Maram is the Cardiac Clinical Rehab Coordinator for the Houston Methodist Hospital. He's been with the Houston Methodist Hospital for the last 31 years, in which his function is to design exercise programs for patients based on their cardiac needs. He conducts stress tests, pulmonary function tests, as well as strength and endurance testing. And so what we're going to do first for this particular section, we're going to talk about the physical activity and how to engage physical activity as part of your regular lifestyle when managing heart failure. As we all know, physical activity is a very important component. So we have a short video, about a 10-minute video that we created that outlines physical activity principles for strength training as well as endurance training. So let's go ahead and show that video now, please.
Hello, my name is Wayne Brewer. I'm a physical therapist and a heart failure patient.
Hello, my name is Alapur Maram. I'm exercise physiologist.
So the purpose of this video here today is to teach you some basic exercises that you can do at home to improve your cardiovascular fitness and to improve the strength of your muscles.
We strongly encourage you to do these exercises for your own health to increase the level of strength and endurance.
Now, this video will be divided into two phases. The first phase will be to teach you some general guidelines and some exercises to improve your aerobic fitness. The second phase of this video is to teach you exercises specifically to improve your muscles. So let's get after it. Now, before we do any aerobic exercise, we want to make sure that we're safe. Let's start out by taking your heart rate. So in order to take your heart rate, you need to take your 2 fingers on one side along the thumb side of your wrist and count how many times it beats for 60 seconds. Once you've counted the number of times it beats, the guideline is so that when you're exercising, you don't increase your heart rate by more than 20 to 30 beats over that resting number. We also want to ensure that we're exercising at least 4 to 5 times a week for at least 10 to 30 minutes at a time. You don't have to exercise 10 to 30 minutes all at one time. The next thing is intensity. We want to make sure that you're exercising enough to where you can feel yourself getting slightly out of breath, but not so tired where you feel lightheaded or dizzy. The first exercise you're going to do is marching in place. You're simply going to march, lifting your knees up, alternating, swinging your arms in a nice, even pace. Now, you can increase the difficulty by picking your knees up higher or swinging your arms further. Another option is you can pick your knees up faster. Now, for those of you who have poor balance, you can also use a walker or a table or chair. Simply by holding on to the walker, table, or chair, Allah is demonstrating this using a walker, you can maintain your balance and still do the exercise. The next progression is raising opposite arm, opposite leg as you're marching. As you raise your opposite arm with the opposite leg, you're challenging more muscle groups to be used to elevate your heart rate. The next exercise will be walking around an object. You can use a walker or a cane or a table, walking around the object, keeping a pace, and then you can change directions. You can also utilize a metronome to help keep the pace. The next exercise you can do is called side-to-side skips. So similar to the last exercise in which you were walking around an object, this time you're going side to side, kick the leg, side to side, kick the opposite leg. You can use a metronome to stay on pace, increase the speed of the metronome to challenge yourself to go at a faster pace.
For the next activity, Wayne shows you how to do the step-ups. Just put one foot on the step and bring the other foot next to it, and then easily and slowly go back at the first situation. So for this exercise, keep your balance equal and look forward, keep your shoulders up. Do not hold your breath, breathe, and continue with the exercise. Maybe 15 to 20, or as long as you can continue to reach your goal. If you need to use the walker, for this exercise, you can hold on to the walker and continue with your exercise to keep your balance in case if you need some little help from the walker. So for the next exercise, you are doing a little bit of boxing. You can do it a little bit slow or a little bit faster. Just depends on how you would like to do it. Don't do it so fast that makes you very tired. But continue with punching. If you want to hold on to the walker, you can hold on one hand to the walker and do one arm and then do the other arm. So by alternating these exercise, you will get some benefit on your muscles, upper body muscles. The next exercise is boxing with alternating marching. As you see, you throw punches and also alternate your movement of your legs, knee up and down and keeping your balance. Look forward and continue with a good pace of boxing. Next exercise is yoni jacks, and as you see, you can move your arms and legs on the side. If you have balance issue, you can hold on to the side of walker and perform this exercise. Yeah, remember to check your heart rate after each exercise that you perform.
So the next type of exercise we're going to teach is resistance training. The whole purpose for resistance training is to get the muscles stronger. Now, you may ask yourself, how do we do resistance training? Well, there's based off 4 principles. Frequency. You should resistance train at least 2 to 3 days a week with a day's break in between. Next, you may ask yourself, well, how heavy or how intense? Well, you want to pick a weight or a load so that when you pick it up, it should feel about 11 to 13 on that RPE scale that we gave you. Next, how much? Well, you want to pick a load that your muscles get tired after about 10 to 15 times. Now, you may repeat this 10 to 15 times 2 to 3 sets, but you want to make sure you rest for at least a minute in between each set. Now, what type of exercises can we do? We're going to teach you exercises in this video that works every major muscle group. We're also going to teach you exercises that involve common movements that you may do at home and that involve common activities that utilizes weights, rubber bands, or even just simply body weight. So let's get after it. So the first exercise we're going to learn to improve the strength of your muscles in your legs is called sit to stands. So simply what Allah is doing is he's sitting up straight. He's utilizing his hands to help push himself up into the standing position, and he's utilizing his hands to help lower himself. This is level 1 for this exercise. Also, you'll notice that Allah is using a pillow. So for those of you who struggle with standing up from a chair, you can use a pillow to elevate the seat of your chair. Now, level 2 for this exercise will be to not use your hands. So what Allah is going to do is fold his hands across his chest and do the same exercise. This puts more of a challenge on his upper legs and hip muscles because he no longer is able to use his upper body. The next progression of this exercise is level 3, in which Allah will perform the same movement, however, holding on to some resistance, such as a pair of weights or water jugs or even rubber bands. Remember, the whole purpose of this exercise is to provide enough resistance so that your muscles fatigue between 10 to 15 repetitions with a feeling of exertion between 11 to 13 on that RPE scale that we gave you previously. The next exercise is called the overhead press. In order to do the overhead press, you're going to need a pair of dumbbells or water jugs. You're going to grab these items, place them at your shoulders with your elbows out, and you're simply going to lift them up overhead as high as you can and then bring them down. You're going to pick a load so that your muscles get tired between 10 to 15 repetitions. Remember to breathe. You want to exhale as you push your arms up, inhale as you lower your arms. Keep your back straight. For those of you who are able to perform this exercise in standing, you will challenge more muscle groups if you do this exercise in standing. The same movements apply. Start with the weights at shoulder height and simply press your arms up overhead as you exhale. Make sure you keep your back straight and look straight ahead as you perform this exercise. Okay, so the next exercise we're going to do is called lunges. These are great exercises to work and to strengthen your legs. So we're going to divide this exercise into level 1, 2, and 3 in terms of easy, medium, and most difficult. Level 1, simply, you're going to use an object to support your balance. You're going to have one foot in the front, the other foot in the back. You're going to keep your back straight. Now, breathing. You want to make sure that you breathe so that you inhale as you go down, exhale as you come up. You're going to repeat that 10 to 15 times and then switch legs. Now, if this exercise is too easy, such that after 15, the muscles are not tired, you can go to level 2. Level 2 is the same exercise, but not holding on. So here's what level 2 looks like. Same thing, one leg in the front, other leg in the back. Keep your back straight. You can have your hands folded. Breathe as you go down. Then you switch sides. Now, if you've done that 15 times and it's still not challenging your muscles, you can hold on to light weights. A pair of dumbbells, water jugs will do, and you do the same thing. Hold on to the weights at your side, step back, breathe as you go down, exhale as you come up. You repeat 10 to 15 times, then switch sides. Again, you can always add more weight if you need to, and also you can repeat this 10 to 15 times again on each side after a minute's break in between each set. So the next exercise we're going to teach is called the seated row. The whole purpose of the seated row is to increase the strength of your muscles of your upper arm and your upper back. In order to do this exercise properly, you're going to need a piece of band or tubing as such. Now, we need to make sure we safely secure the tubing at the bottom of your feet. Sitting in a chair, you're going to straighten out your knees. You're going to wrap the tubing at the bottom of both feet. You're going to crisscross your hands so that we anchor the tubing around the feet properly. Keeping your back straight, you want to just bring the feet out wide to put some tension on the band. You're going to simply pull the band back towards you, squeezing your shoulder blades, and then let your elbows come out straight. Now, as we do this exercise, we're going to make sure that we breathe properly. Make sure that you breathe in through your nose, out through your mouth, in through your nose, out through your mouth, as you perform this exercise. So the next exercise we're going to do is called the bridge. The purpose of the bridge is to increase the strength of your hip muscles and the muscles in the back of your legs. So here's how you do it. First, Allah is lying flat on his back with his hips and knees bent. He has his heels flat on the ground. What Allah is going to do first is sort of tense up his stomach muscles first, keeping his back straight, and he's going to slowly lift his hips up off the ground. As he lifts his hips up off the ground, he's going to breathe, and he's going to tighten up his hip muscles, hold for 5 seconds, and then let them back down. Then he's going to repeat, hold for 5 seconds, and let it back down. Now, to make this exercise a little bit more difficult, what Allah can do is if he straightens his left knee, now he can lift his hips and knees up using just the right leg. That's much more difficult. So now the next variation of this exercise will be having the knees a little bit straighter than previous on the heels. And then what Allah's going to do is pick his hips up, pressing through the heels. He's still going to keep his stomach muscles tight, holding for a 5-second count as he breathes, and then lowers back down. The goal of this exercise is to perform this 10 to 15 repetitions or until the muscles of the back and legs get tired. The next exercise we're going to teach you is called bicep curls. This is a great exercise to work the muscles in the front of your arm. We're going to teach you 2 different ways. The first way we're going to teach you is with the rubber band. Now, in order to use a rubber band safely, you're going to have to secure it to the bottom of both feet. So you're going to step on the rubber band, making sure that the middle of both feet are standing on the band. Spread your feet out nice and wide, about shoulder width apart, elbows straight, and you're going to have your palms facing up towards you. Next, keeping your back straight, you're going to simply bring your arms up towards your shoulders and then let your arms slowly go back down. As you do this exercise, you want to make sure that you're breathing properly. So what you want to do is take a deep breath in, breathe out, breathe in, breathe out, and repeat 10 to 15 times. Another option, instead of using a rubber band, is to use light weights such as a dumbbell or water jugs, and simply just bringing the jugs up towards you and letting them back down. The next exercise we're going to demonstrate is called the tricep extension. The tricep muscle is a large muscle group that's located in the back of your upper arm. What Allah is demonstrating here is he's going to use his right arm as an anchor held by his chest, and the left arm is going to perform the exercise. Allah is starting out with his left elbow bent, and he's going to simply straighten his left elbow downward, making sure he keeps his elbow at his side. Allah is going to perform this exercise 10 to 15 times. And then once he's finished 10 to 15 times, he'll switch sides. He's going to switch the band and perform 10 to 15 repetitions on the other side. So the next exercise is called the heel raise. The purpose of the heel raise is to strengthen the muscles of your calves. So this exercise is very simple. What you're going to do is either standing by a sturdy object such as a table, chair, or walker, you're going to rise up on your tiptoes, hold for about 2 to 3 seconds, and then come back down. Now this exercise, you can probably perform more than 10 to 15 repetitions, which is fine. You're going to do as many as you can until you feel your calf muscles starting to get tired. Now for those of you who want an extra challenge, you can do it on just one leg. So lifting just your right leg up. Now you see Allah performing the exercise solely on his left leg. You repeat as many times as you can on one leg, switch, and then do the other side. As a variation to this exercise, what Allah can do is he's going to rise up on his tiptoes, and then he's going to lift his feet up. So on his tiptoes, hold for 3 seconds, come back onto his heels, lift his foot up. Lifting the foot up works the front of the ankle. This is a useful variation to work the entire muscles of the lower leg. Now Allah is demonstrating this exercise as the next level, doing it on just one leg.
Thank you very much for watching this video. We're hoping you learn more about the type of exercises that you are doing. We would like you to give us a call, and if you have any question about exercises, about participating in the cardiac rehab program, and let us know. Make sure you speak with your physician before you start any kind of exercises.
And remember, as you're doing these exercises, if you experience any of the following symptoms, such as lightheadedness, shortness of breath, profuse sweating, chest pain, or dizziness, stop the exercise immediately and contact your physician. Thank you, and go exercise safely.
Hey, well, I hope you've enjoyed our video and taken some really good information from this video. And we have Allah in the studio with Dr. Bhimaraj, and we'll take any questions that you may have with regards to the physical activity portion of this conference.
Yeah, I think I want to remind people, please send in questions through the 2 mechanisms that have been highlighted, text or online. And if you're on the Zoom watching, you can type in your questions about any of the physical activities. So maybe Allah, you can talk about, the rehab programs are something which I feel, especially in the past, we used to have insurance issues to get people signed up for the rehab program. And maybe you can talk a little about why it is important to sign up for a rehab program, and who are the people who benefit from it. Do you have to be hospitalized, or anybody who's never been hospitalized can go through it?
Sure. Good morning, everyone. I'm Alapur Mahram, exercise physiologist. Thank you for watching this program. I hope you learned some strength exercises out of 1,000 different strength exercises that you can do and are able to do. I'll be happy if you have any question to give you the best advice I can.
Yeah, then we have some questions that are coming on, and maybe I can take a stab at this, and then maybe we get the both of you to comment. The question is, can exercise help cure heart failure? I think if you look at studies and evidence of exercise, especially cardiac rehab programs or cardiac exercise programs designed for patients with heart failure, there's evidence to show that people who get this organized programs, especially when it's focused on heart failure based exercises like you've seen, it actually improves your ejection fraction, and it also makes people live longer. So I think it's probably an overstatement to say that it'll cure heart failure, but it definitely makes you live better and do better with your heart failure. What are your comments, Ala and Wayne?
Well, definitely exercise is important along with the medication patient can take. It is the best way to feed your body with better oxygen, better nutrition to fight the disease. If you have a stronger heart, you can feed your body better. That's why one of the aspects of exercise is to have all the energy that you need through the exercise and give it to your body to function better. And of course, it is not as a replacement for medication, but it is along with medication to get stronger and fight the disease. If there is anything that you can do, you need to get up at least for a few minutes a day and spend time for doing some strength exercise, aerobic exercise, and these go side by side. It is not only a strength exercise. You need to spend about 1/3 of your time with strength exercise and 2/3 with aerobic or endurance to have your heart work harder with more pressure, send blood and oxygen and nutrition to your body to have a better health. So I see exercise as a great help to be healthy, and this is like you eat your lunch, your dinner, and you have good sleep. Your body in general, you will help yourself to get better.
Wayne, any comments?
Yeah, I think along with all the things that you two mentioned is that, exercise, a lot of studies have shown that exercise for individuals living with heart failure has reduced hospitalizations, also has reduced morbidity and mortality. So along with a program like Ala mentioned that comprises medications, follow-up visits with your physician, exercise is a very important part. And also, we have to realize that with regard to quality of life, when we want to be able to do certain things that requires a level of exertion, if we have a stronger heart and we have a stronger muscles, well, then that given activity, we're working at a much lower portion of what we're capable of doing. So we're not stressing ourselves as much when we become more fitter. So exercise becomes a very important piece of living with heart failure.
Yeah, and I think one of the paradigms that people need to understand is when we talk about conditions like congestive heart failure, it's not just about the heart. And there's a lot of research that's being done, and some has been identified already that it's not just the heart, but people with congestive heart failure have changes in their muscles, the way the muscles consume energy, the way the muscles react. So it's almost like the intent of exercise is having better muscle health and also having a better, as Wayne pointed out, having a better mental health and also having a better physiology for the heart as such. And that kind of leads into one of the questions that's come in saying, does the risk of heart attack increase with exercise? And not to complicate things, as Ala had pointed out, you always want to ask your doctor, and then when you go to a program, they actually check with your doctor and make sure there are no limitations. And what that means is just by the fact of having congestive heart failure and you have do exercise, it does not increase the risk of heart attack. Exercise is always good. Now, it's a different story if you have a known blockage and you exert yourself to the point of having increasing demand on the heart. Will you get chest pain? That's possible. So always you want to learn to listen to your body, but as such, exercise does not increase the risk of heart attacks. If any, regular exercise decreases the risks of heart attacks in the future, in general, whether you have heart failure or not. The only caveat that Wayne pointed out is to keep track of your heart rate, and more so, maybe the both of you can comment. Some individuals with heart failure have a defibrillator, have a pacemaker. So are there any specific precautions that they have to take, or do they always have to check with their doctor on monitoring the heart rate in the limits that you want the heart rate to go from?
Sure. About the heart rate, we would like you to speak with your physician first and make sure there is a limit on your heart rate, not to exceed that level, and then start establishing some kind of exercise to keep you healthy, help you with your endurance and strength. In general, we would say if you are exercising with heart disease, try not to exceed your heart rate more than 20 to 30, maybe to 35 or 40 beats above your resting heart rate, which is estimated it's good exercise. You get good benefit of endurance and strength. But if you go further than that, we try to avoid it unless your physician makes a remark or set for your maximum or sub-max heart rate when you exercise. So in general, 20, 30 to maybe 40 beats above your resting heart rate should be reached with your exercise program. Even if you don't reach that number or percentage, it is fine to do some activity. You always going to get benefit of exercise. Heart is a muscle, right? Like your arms, your legs. So if you make your heart stronger, you're going to fit your body better, and you're going to stay in a healthier stage.
And I think also, to piggyback off of what Ala said too, is that many of us who have heart failure are on medications that don't allow our heart rates to really increase with exercise that well. And so sometimes the heart rate may not tell you exactly or be the most accurate indicator in terms of how intense you're exercising. So you may have heard me mention in the presentation about an RPE scale, or rating of perceived exertion. I just want to share with you what this looks like, and we can share it with you. When you're exercising, you want to kind of keep it, kind of around the light to medium range, about that 11 to 12 range, if you can. Now, and this is all subjective. This is all strictly subjective with regards to the exercise intensity. So we'll provide this rating of perceived exertion, or RPE, for you in one of the handouts. But just recognize that some of you that may take medications like beta blockers, that may not cause a heart rate to elevate. So you may be trying to exercise to try to get that 20 or 30 beats that Ala mentioned, and may not get that. But look at subjectively how you're feeling and go by that, and use that RPE scale. Keep it around the light to medium range would be the key.
That is great. Try not to exceed more than your level of RPE elevation. If you have taken beta blocker, always go by RPE norm and do not try to reach about 30, 40 beats above your heart rate. That might be not suitable for you. If you're not taking beta blocker medication, that is something that you may consider to reach that number above your heart rate.
Yeah, very useful tips, and I think I love the video that you guys showed, that you don't need to have exotic gyms and equipment to do simple things, and sometimes I think even I've learned in my life that, I've given excuses not to be physically active because we're so busy. Only realize that once you get into a routine, it's those simple exercises that you can do at home or with a partner. So I'm glad both of you kind of made that video, which is very simple. And I want to remind all the viewers that the whole conference, including those videos, will be available on our YouTube channel after the conference, just like the previous conferences. So you can always go back, play them on the YouTube, pause, do the exercises, whichever way. I think we're coming to the end of our program with the physical activity before moving on to the nutrition. Ala, I think you had a few words to talk about our cardiac program and how to access it.
Sure. Fortunately, this time, many heart patients have a chance to participate cardiac rehab programs through the nation. It covers about 6-7 different kind of heart disease, from heart attack to heart transplant. I think the slide is over that you can look at them. So a simple stent qualifies you to participate in the cardiac rehab program. That is about 3-month program of exercise that your physician can make a prescription for you or make a referral for you to participate. And majority of these heart diseases are covered by insurance and for sure by Medicare as well. So Methodist Hospital has different locations in town which provide the cardiac rehab program, and we all will be happy to see you in our program to make yourself healthier and stronger. The information will be in the computer, and you can contact us at Cardiac Rehab if you have any question or further information. We'll be happy to provide it to you.
Thank you, Ala. Before we, I think looks like there's one other question that came on. We can probably quickly address it before we move on to the nutrition section. It says, what if your resting heart rate is 55 to 59 and you find that walking at a good rate gets your heart rate up to 105 to 110, or the elliptical does the same? So I guess the question is that okay to go up to that heart rate from 55 to 110?
The reason we are asking you to consult with your physician is as an example. So if everything is fine, you might have originally lesser heartbeat, resting heartbeat, which is fine. You can increase your heart rate, but it is not necessarily to stop if you have above 40 beats per minute on your resting heart rate. It is fine as long as you don't feel different, as long as you're not getting any kind of symptoms. Yes, you can increase your heart rate above that number, but this is all with precautions. So we want you to understand that we don't encourage you to go above what you can do or what we recommend. So for your own safety, it's better to discuss it with your physician. If they say that's fine, definitely you can go over.
Yeah, typically when you have heart failure, the goal of some of the medications, especially the beta blockers, is to actually keep your heart rate in that range, 55, 59, 60, as long as you're feeling okay. So for a straight answer to that question, most of the times, unless there is some variation, it's okay for your heart rate to go to 105, 110 at the time of exertion, and as long as it comes back, that's expected. And if you're feeling well, you should be okay. With that, I think we'll wrap up this session on physical activity, and I want to thank Wayne and Ala and our studio crew for that wonderful video that we made. We will move on to the last part of our entire conference today, but one of the exciting parts. I think things like physical activity and exercise and nutrition are really some of the gaps where I feel if somebody asks me how to cook low sodium diet, I don't know anything about it. And if somebody asks me what exercises to do in my clinic, it's not easy for me to say this is what you have to do. So one of our intents to focus on things which you might not be able to get in your physician's office are to create these resources for all of you who are watching. And I think with that, I'd like to introduce our guest here and a part of our Methodist team, Angela Snyder. Angela is a registered dietitian with over 15 years of experience in preventive nutrition and patient education. She's been a part of this conference since inception and really has been instrumental in creating this nutritional perspective, working and partnering with some of our chefs in town, helping us kind of come up with practical advices. We have Peter Cox is the chef who's partnered with us for this conference. Unfortunately, he was supposed to be here live to kind of answer some questions, but he's not able to make it. We do have a nice pre-recorded video that both Angela and the chef made, and Peter Cox is a executive chef right now at the Weston in the medical center. But he comes with a lot of experience in culinary area, and he was in California, Long Beach before this, and prior to that headed some of the well-known restaurants in Las Vegas, and we're excited that he had agreed to work with us. So with that, I'll let Angela say a few words on the importance of nutrition, and then we can then transition to that video.
Thank you, Dr. Bhimaraj, and thank you for having me today. It's always exciting to be with you guys and help just lend the nutrition support to the Heart Failure Conference. I know, like you mentioned, Dr. Bhimaraj, that nutrition is such a big part of keeping a healthy diet is going to help you manage your heart failure better. And so one of the keys to that, and the one we tend to discuss the most, is the low sodium aspect and the low salt aspect to that. For patients with heart failure, we recommend about 1,500 milligrams or less of sodium per day. This can be difficult to achieve, especially just because even if you never put any table salt or any kind of salt on your food, you could likely be exceeding that 1,500 milligram mark just because there's sodium in so many other foods that you may or may not recognize, especially whenever we're talking about processed foods, processed meats, frozen meals that are processed, also canned vegetables, things like that that we can perceive as healthy can have a good amount of salt and sodium in them. And so I think the goal with this recipe from Chef Peter, he did a great job actually putting together a really tasty recipe that's also very reasonable in sodium and very good for your overall heart health. I think one of the biggest complaints I hear from people who are trying to follow a low sodium diet is that they feel like their food doesn't have a lot of flavor. So my recommendation is always add flavor wherever you can that's not coming from salt. So we can absolutely impart flavor in our food with herbs, with spices, with acid, with lemon and vinegar. There are a lot of different ways to make our food very tasty, but also very healthy and low in salt. And so the recipe that I was honored to go and meet with Chef Peter and also experience him preparing this recipe. It's a great recipe. It's very heart healthy. It's very reasonable in sodium. And I can tell you firsthand, it has a ton of flavor in it. So with that, we'll go ahead and cue the video and let you take a look at this great recipe that Chef Peter created.
Hi,
Hi, and welcome to the Heart Failure Management Conference. My name is Angela Snyder, and I'm a registered dietitian with Houston Methodist.
And I'm Chef Peter Cox, and today I'm going to be doing a seared salmon with a wheatberry and hemp seed pilaf and a kale and almond pesto. All right, so first thing that we're going to want to do is start making the pilaf. What's really important, especially when you're not cooking with a lot of salt, is trying to impart as much flavor as possible. So the first thing you're going to want to do is get your wheat berries and your hemp seed, and you're going to want to toast it in an oven at 325 degrees just until it changes color slightly and it becomes kind of aromatic. It's going to have a nice nutty flavor after that.
The chef here is using wheat berries. Wheat berries are a whole grain. They're actually the whole wheat kernels. These are very high in fiber and magnesium. They're a great substitute for rice or any other refined grain. Hemp seeds will add a great nutty flavor and texture to your dishes. They're high in healthy fats, thiamine, and copper.
After that, you're going to take your avocado oil, just get a little bit into the pot, and then you're going to start sweating off your vegetables. So it's going to be about 2 ounces of onion, and then the same amount of carrot and celery. We're going to throw in a little bit of garlic, just a couple pinches, and we're just going to saute that. And when it turns translucent, we'll add in the wheat berries, and then to your preference whether you want to use vegetable stock, low sodium vegetable stock, or water. Vegetable stock will impart more flavor, but it does have slightly more sodium obviously than water does. So we'll just wait for this to get going. Now that it's starting to get translucent, the vegetables are about ready. I'll just go ahead and add in the wheat berries. Toast those a little bit more in the pot. And then we'll go ahead and add in the vegetable stock. You're going to want to go about 1 inch over the wheat berries. And then you'll just turn that down to a low simmer. While that's working, we'll go ahead and make the pesto for it. So I'm going to take my kale, parsley, some crushed garlic cloves, a pretty healthy amount of rosemary, and then we'll do a little bit of pecorino cheese. I'll just shave that into it. And we're going to add in juice from 1 lemon. Turn that on in the blender. And just drizzle in some extra virgin olive oil. You want to turn it off and just scrape the sides every once in a while just so you get all those chunks nice and smooth.
Chef here is using kale, parsley, and rosemary in this pesto. The kale is very nutrient dense, high in vitamins A, vitamin C, and fiber. The rosemary and parsley are there to add flavor.
While that's going, you want to get your salmon ready to sear off. So you want to pat it dry, just make sure that it really doesn't have any moisture left on the outside of it.
Salmon is a great choice of protein. It's high in heart-healthy omega-3 fatty acids and is very cardioprotective.
We're going to turn our pan on. You want to get it nice and really, really hot. And we're going to use avocado oil because it has a much higher smoke point than extra virgin olive oil. Because when extra virgin olive oil smokes, it turns carcinogenic. Let that go a little bit more. You're going to want to wait to add the salmon into the pan until the oil is really shimmering and is very, very thin. All right, pesto's ready to go. And we'll do the salmon skin side down. You want to sear it really hard. And if you want, actually baste the top of the salmon with a spoon. It'll help kind of seal the other side of the salmon. So it's really important to wait to try and flip this salmon until the skin just releases from the pan. That's how you know the proteins are fully cooked and ready to go. So I'll get a quick sear on this other side. You can kind of go, obviously, however you like to eat it, but I prefer it medium or medium rare. So seal it on that side and then flip it back just to finish on the skin side. So it gets really nice and crispy. And over here, I have the finished pilaf. Just get that warm. Then to plate, we'll put a little bit of this pesto that's finished on the bottom. We'll put the pilaf right on top of that. We'll just sprinkle some of the toasted hemp seed over the top of that. It just adds some nice texture to it. Pat dry the salmon and kind of get all that extra oil off of it. We'll just finish it with a little bit more pesto on top. And then I'm just going to finish it with a little bit of celery leaf with some lemon zest. So a little bit of lemon. This citrus is another good thing when you're not using a lot of sodium, just to kind of impart more flavor. Just gonna toss these a little bit and then just finish it right on top.
That was amazing. I think I'm hungry now. I'm sure everybody at home are probably hungry too. I really want to thank the chef who couldn't be here today, but that was a beautiful presentation by the chef and Angela for mediating the nutrition aspects of it. And I think the part that you mentioned on the low sodium diet and the focus on the low sodium diet is because when we talk about heart healthy, there's always a focus on low cholesterol. And if you just focus on low cholesterol, then it becomes, you ignore the low sodium, that becomes an issue. So it's important to eat heart healthy, but at the same time, the sodium becomes a crux for patients with congestive heart failure. And I want to remind our viewers to, any comments or questions, please send them in through the two channels that are listed on your screen, and then if you're on the Zoom, please type in your questions on the chat. We did have a question from before that I tabled until we get to this section, Angela, and maybe your insight and thoughts would help. More specifically, the question was about, has there been any studies done that have shown the utility or not, or benefits of plant-based diets in heart failure? I know there's a lot of discussions in plant-based proteins and plant-based diets. So one, in general, what are your thoughts about plant-based diets and heart health? And do you know of anything specific when you're eating plant-based diets? How do you manage the low sodium part of it?
And that's a great question. So in general, the studies that we do have and the research that we do have really do support a plant-based diet for heart health. So for overall heart health, we know that if you're eating primarily a plant-based diet, that's assuming you're getting a good amount of fruits, vegetables, whole grains, plant-based proteins from beans, legumes, lentils, things like that. We know that people who eat a plant-based diet do tend to have overall lower cholesterol and overall improved heart health. That being said, I'm not familiar with any research specifically done on plant-based diets and that are specific to heart failure. But from my perspective, if you are eating a plant-based diet that's going to be good for your heart, then you're going to be benefiting your heart to help it function the best it can overall. And that should also help patients who have heart failure as well.
Yeah, and I think you brought up a good point about having a kind of a holistic meal which has enough aspects which are healthy. And in that regard, the only studies that have shown benefit in heart health, like preventing heart attacks for the future, is when you eat what we define as Mediterranean diet. So if you look at Mediterranean diet, exactly the ingredients that Angela talked about are what are embodied in it. To that extent, I don't think there's any specific studies of plant-based diet in heart failure, but I do want to point out that you can, if just by eating plant-based diet, you can still eat unhealthy if you don't pay attention to what you're eating. And I've seen that firsthand. You know, it will be a plant-based diet if you eat a lot of potato and rice, and that's a lot of carbohydrates. Sodium-wise, I think whether it's plant-based or non-plant-based diet, the precautions you take as reflected in the video can be applied to either of them. Then we have another question which is to the different types of oil, do they vary in sodium, and which one is the most recommended best to use for heart failure? So Angela, I think one is which is a better oil for heart health, but then I guess sodium wise, is there a difference in the types of oils that you can use?
Another good question. So no, there really is virtually no sodium in any of the oils that are going to be out there on the market. So your vegetable oil, canola oil, olive oil, sodium isn't a concern in those oils. Now, the type of oil for overall heart health is going to be, we do want you to make specific choices there. Chef Peter did a great job actually showing you really the two that I recommend the most. We know from a research standpoint, a lot of which is coming from the Mediterranean diet, research that olive oil is going to be good for your heart. Olive oil is going to be our number one choice if you are putting it in a salad dressing, if you are lightly sauteing your food, just sauteing vegetables over a medium heat or less, olive oil is going to be our oil of choice. Chef Cox demonstrated he was searing that salmon at a very high heat, and he was totally spot on with recommending the avocado oil for higher temperatures. So avocado oil does have a higher smoke point. It's still going to be a very heart healthy oil, but it's not going to what we call smoke and kind of disintegrate until a much higher smoke point. So if you're, again, if you're not putting any heat on it, or you are using very low heat, olive oil would be your first choice. And if you are going to grill, or you're going to saute at a very high heat, or you're going to roast vegetables, like I tend to roast vegetables at a high heat, like a 400, 425, then that's when you switch over to that avocado oil. So those are going to be your two best options for heart health.
No, great suggestions and comments, and I think I want to remind our viewers that the effort to focus on nutrition, eating the right kind of food with the right kind of restriction for your conditions is extremely important, and gets complicated because a lot of times with congestive heart failure you have other things. So if you have blocked arteries, which is coronary artery disease, you have congestive heart failure, you have diabetes, you have some kidney dysfunction. So now you're talking about low sodium diet for heart failure, low sugar diet for diabetes, and then you have low cholesterol diet for blocked arteries, and then you come to low potassium diet for kidneys. I feel when I talk about this, it's almost overwhelming that it's probably best not to eat anything. So Angela, what's your suggestion for people when they're working with their doctors in resources in the context of, should they list each of their condition and try to figure out how to eat? Or would you recommend that everybody should get a nutrition consult? I know sometimes it's not always covered by insurances. What are your thoughts in that regard when it gets so complicated?
It can get complicated. So what I will say is we say that if it's in terms of diet and exercise and other lifestyle modifications, the saying goes, if it's good for your heart, it's good for every other part. So just because you're exercising for your heart health, or you're trying to eat a healthy plant-based Mediterranean style diet for your heart health, even though those are going to be the best things for your heart, that also benefits other areas of your body. We have ongoing research about, exercise and healthy diet being good for your mind and good for cancer prevention and things like that. So just because you're eating a heart healthy diet, don't think that it's only going to be healthy for your heart. It really is going to be good for your entire body. With that being said, I know we talked about the Mediterranean diet, and we do have a lot of really great research that says the Mediterranean diet is going to be the best eating pattern for your heart health. But a lot of studies also show that the Mediterranean diet pattern is also good for people who have diabetes as well. And so I think just think about more of the eating pattern. So, if you're eating whole fruits, whole vegetables, whole grains, lean proteins, that is going to fit into a heart healthy diet, but that's also going to be well within the parameters of what we would suggest for people who have diabetes as well. I think the one caveat comes to whenever we do throw in certain types of kidney and renal disease, because the potassium element that you mentioned, a lot of healthy fruits and vegetables do contain potassium, and so we do have to modify that a little bit more. So my recommendation would be, if you have diabetes or if you have any kind of renal disease or kidney disease, that's whenever I would really encourage you to talk to your doctor about writing a referral for you to see a registered dietitian, because it can get very confusing at that point. Even if you don't have those things, you can always come see us as well. But that specifically is whenever we really have to take a look at specific foods and specifically what you like, what you don't like, what you're including, what you're not including. And that's whenever I think you need more guidance from a registered dietitian. But even if you're confused about a heart healthy diet or don't exactly know what a plant-based Mediterranean eating pattern is, a dietitian can always help you out and give you some guidance there as well.
Yeah, I think I've gotten more into the practice of seeking out dietary resources, and I think institutions like ours have the resources. And sometimes I've also realized that I would urge individuals to call their insurance company, because sometimes I've noticed that the health insurance companies have their internal resources so that they can promote your health. It's not always a prescription from the doctor to go to a dietitian, but you have all these available resources that can work. There's I think an interesting question from some of our colleagues and partners from Jordan who I think Dr. Tabalat is asking, is there any data on intermittent fasting in heart failure patients? And I think more relevant to the Ramadan season is going on, and it comes to question of, should we allow the patients to go on fasting? I'll take a stab at this and then let Angela see what your thoughts are. I think intermittent fasting has been an interesting area in general, which fasting in general has been shown in animal studies that a period of fasting actually activates anti-aging genes. It's mostly in animals. I think the benefit of intermittent fasting for weight loss and heart health is being studied. I don't think there's any active studies for heart failure as such. I personally, with no data or evidence to quote, I personally don't think the intermittent fasting concept hurts the heart failure patients. Is there true benefit that it'll cure heart failure or do better? I'm not sure about it. I think what intermittent fasting also validates is there's more data that's been substantiated in the last decade that it's about the amount of calorie intake that you do, and if you overconsume calories, in general, it's not good for your health. Those are my thoughts and comments, and I'll let the expert speak about intermittent fasting and if there's any data at all for heart failure.
Those are good questions. So I agree. I haven't seen any data on specifically intermittent fasting with heart failure. We have some preliminary research about intermittent fasting and diabetes and weight loss and things like that potentially look promising. I will say I do have a lot of patients come in and say, well, I'm not hungry in the morning, so I normally skip breakfast, so I guess I'm intermittent fasting now. That's not quite what intermittent fasting is. I don't think skipping breakfast alone is really going to qualify as an intermittent fasting. But I do think there are some potential benefits, especially whenever we're cutting off that, the last time we're going to eat. If we're cutting that off earlier, I would say anecdotally, I have patients that do better, not with starting to eat at noon and then, stopping at 8 p.m. If we can get that window a little bit earlier to where you're, starting at 10, ending at 6 or something along those lines, that's whenever your body's using the energy, right? So you're up, you're at work, you're going to go exercise. So you're actually burning some of that energy, by 6 o'clock, if that's your last meal. You will have consumed all of your calories by then, and you will also balance some of that out with the energy that you're burning. On the flip side of that, if you don't eat a whole lot all day and then wait until eat a big meal at 8 p.m. and then you go to sleep a couple of hours later, that tends to be where we don't see intermittent fasting being as successful as if we would prefer you to eat more of your calories and bump up that eating window earlier in the day to where your body is utilizing more of those calories. But I think a lot more to come from research about intermittent fasting. And I think it also just comes down to compliance and how easy it is to actually stop eating at a certain time at night. So more to come from a research standpoint, I would say.
Yeah, I think if I have to guess with the intermittent fasting, as long as you're not overeating when you're breaking your fasting and then eating things which can still exacerbate sodium consumption and fluid intake, I'm presuming it should not be of any harm and should be beneficial, if any. I think with those are really good questions and discussion points and really practical tips, Angela, that you shed light on. I always learn a lot just by this conference, by talking to you, talking to Wayne, because these are tips and things that we don't learn in med school. So it's always good and refreshing to have your perspective. I want to thank you. I want to thank the chef, and I think as we're coming to the end of today, I want to thank all of our audience, local in Houston, in the state, and national, and also international. We're honored and really happy to have some of our partners down in Jordan who were gracious enough to share this with their patients and use this resource. As mentioned, this conference will be available on our DeBakey YouTube channel, which you can go and look for it. And not just this conference, but the previous conferences are also available for resource for just education. And some of the previous conferences we highlighted and touched upon in a little more detail. And hopefully in the future we will go back to doing this in person where we can have a much more interactive forum. I think before we wrap up, I'd like to thank the supporters for this program: Abbott, AstraZeneca, Boston Scientific, Friendly Faces Senior Care for the program support. And then I also want to thank the DCM Foundation, Dilated Cardiomyopathy Foundation, that is Heart Failure Society of America, Houston Methodist Cardiac Rehab and Texas chapter of American College of Cardiology for informational support. And as you notice on the screen, you can use that QR code. And even after we wrap up with the conference, the virtual exhibit hall will be accessible for you for a little bit. And you browse the information. Some of these sites have really good information and efforts that are combating this whole disease process of heart failure. So we will conclude today with a gracious thanks to our patients who participated on a Saturday, my colleagues from Methodist who contributed to this conference, and especially our DeBakey studio team here who have done a wonderful job in the video production especially, and then today's efforts in making this conference available to everybody. Thank you very much, and you have a good rest of the weekend.